So good afternoon, everyone. We will start with our first session in the 50th ICON Golden Jubilee Indian Cooperative Oncology Conference. It gives me great pleasure to introduce our co-director, Dr. Stalin Chaudhary Bala, medical oncologist from Visakhapatnam, to please start the proceedings. Over to you, sir.
Yeah, thank you. So good afternoon, everyone. We finally arrived at the Golden Jubilee ICON. This is the 50th ICON. So it's always an honor to welcome guests and eminent speakers from the world of oncology to the conference, which has almost reached Golden Jubilee. So as a member of this fraternity, I always enjoy being part of this wonderful event, as it gives an opportunity to meet the greats and in the field, enhance shared knowledge and learn about latest trends in the field of oncology. So we are in one of the critical areas of medicine which needs precision and timely care. I can assure you the 3 days of the conference we spend here will help you take steps forward in that direction. So with that, I welcome you all to the Golden Jubilee ICON and hope we will all have a great time. So without much waste of time, we'll start the first session of today, that Hemonc session. So we have eminent speakers from all over India. So for this session, I would like to invite our chairperson, Dr. Sadasiv Gundeti, who is the professor and HOD, Medical Oncology, Department of Medical Oncology at the prestigious Nizam's Institute of Medical Sciences. You all know Sir very well. Sir was one of the senior most medical oncologists and hemato-oncologists in India. So I welcome Sir for the session.
Yeah, thank you, Dr. Stalin, for your nice introduction, and thank you for having me here as a chairperson for this hemato-oncology session. I think we'll start our program now. So,
yes.
So first speaker, I would like to invite Dr. Santhosh, Kumar, Devadas. So what is new in the management of AML? I think this afternoon we'd like to have all the hemato-oncology sessions, which will enrich our knowledge and our experience also.
Thank you, ICON, for this unique opportunity, 50th ICON, and I get to be the opening batsman. It's a real privilege for me. Just like Rohit Sharma has to bat, I have to start pinch hitting. I have only 10 minutes to do this vast topic. Without much ado, this is what I will try to cover. The changes in diagnosis and classification that has happened recently. Most data with hypomethylating agents and venetoclax, and I'll conclude. Though just because of sheer lack of time, I'll not cover data with CPX351, third generation FLT3 inhibitors, IDH inhibitors, Menon inhibitors in MLL mutated AMLs, gemtuzumab or other monoclonal antibodies, chemotherapy advances, or transplant or MRD studies. Just to delve into the changes in recent classification, the WHO came up with a change in its nomenclature recently in the 5th edition. AML, as we know, has been, irrespective of the blast percentage, we could diagnose AML if there is 821 translocation, inversion 16, or translocation 15-17 till recently. The WHO also added the presence of NPM1 mutation and biallelic CBP alpha to this list of diagnosis without requirement for a blast threshold. Also, it added a new nomenclature of AML with myelodysplasia if molecular abnormalities or cytogenetic abnormalities which are characteristic of MDS is present, and there is a prior history of MDS or MPN. If none of these are there, then you call AML, a patient AML if the blast percentage is more than 20. Also, the WHO has identified the peer use of cytotoxic chemotherapy as a separate diagnostic subgroup, and the presence of a germline predisposition syndrome also as a separate subgroup. The ICC has come up with a hierarchical classification of AML where the presence of 10% blast threshold is required, even in a patient with inversion 16821 or the others which was I was alluding to. And if this is not there, then we classify patients with AML TP53 or AML with myelodysplastic related gene mutations or AML with myelodysplasia related cytogenetic abnormalities. If none of these are there, then we call these patients as AML NOS. If the blast percentage is between 10 to 19%, we have to call them MDS AML. And if it is more than 20%, we have to call these patients as AML. In addition to calling somebody with these names based on presence of these features, there is a need to add an appendix to the diagnosis, which include therapy-related AML, presence of prior MDS, presence of MDS MPN, or a presence of a germline predisposition syndrome. Based on the changes in the nomenclature, the ELN recently published a change in the risk stratification, which there are just the major changes I will allude to. The biallelic CEBPA alpha was changed to the presence of a B-zip inframe mutated CEBPA alpha, which is important, and no more biallelic CEBPA alpha is important. Then the other change is with respect to the NPM and the FLT3 mutations. Presence of a NPM mutation, irrespective of the FLT3, patients will belong to the good risk. Presence of a FLT3, irrespective of the allelic ratio, as we used to look for previously, irrespective of the allelic ratio, patients will belong to the intermediate risk. And the ELN also identified additional mutations that we pick up on NGS. In addition to the RUNX1 and the ASXL1, there are multiple new mutations that have been identified by the ELN that classify patients as belonging to the high risk, which include presence of EZH2, BCOR, SF3B1, SRSF2, STAC2, U2AF1, and ZR-SR2. All of these mutations we will pick up if we send a NGS routinely in our patients. Coming to the treatment options that have evolved over time, since year 2017, we have a plethora of new agents that we can use based on the genetic risk, etc. And we are able to show the door to AML just like Alu Arjun will do to the bad guys. So, most important drug in AML nowadays, we all love it. It is the vitamin V, venetoclax, which has really transformed care in patients with many hematological malignancies, including AML. So just taking just few seconds to describe the mechanism of action, it's interesting to note that the BCL2 inhibition doesn't occur in the AML blasts. The BCL2 inhibition occurs in the stem cells that go on to become blasts. In AML, the BCL2 inhibition occurs, hence there is an increase in the BAX and BIM proteins inside the AML stem cells, which in turn increase apoptosis by releasing cytochrome C. Other mechanism of action of venetoclax is the reduction in oxyphos and amino acid uptake in the stem cells, which in turn cause stem cell death. And when we combine this with azacitidine, which acts on the DNA, there is inhibition of a gene called MCL1, which increases apoptosis of these cells. Coming to the YLA data, the initial data for YLA study where HMA and venetoclax were compared to only HMA was published few years ago. The long-term follow-up data of this was presented recently and published with a median follow-up of 42.5 months. The CR rates with the combination of HMA and venetoclax is very impressive, 67%, MRD negative rates of 42%, and the median time to development of complete remission is only 1.3 months. and the 24 months overall survival is 34.5% versus 16.9%. The median duration of complete remission was 17.5 months. Most important to remember, patients who achieved a MRD negative status, the curve has started plateauing at the time period of 30 months. And this is important to remember in clinic also. In patients who hit MRD negative status are likely to do very well in AML with this combination. So we have all heard of TFR in chronic myeloid leukemia, but it was even a learning experience for me to understand that people are attempting TFR in acute myeloid leukemia. This is a study published, presented in the ASH this year, which is called the PHILO study. It's a retrospective data. This was preceded by 2 other papers, one in Blood Advances, which looked at people who stopped the venetoclax azacitidine because of various other reasons, not medical reasons, and they found that TFR after stopping the venetoclax was 45.8 months in the stop group. And in the blood paper recently published, patients who had a MRD negative status, the TFR was 88% at 2 years. In this present abstract published in the ASH, about 62 patients received Ven-Aza. The median duration of these cycles were 4 cycles. The overall response rates were impressive 92%. Patients stopped Ven-Aza for hematological toxicity or patient preference or other extrahematological malignancies or poor general condition. And they demonstrated a OS of 44 months in the overall populations, and the patients who had a MRD negative status had a median OS which is not achieved, and a 2-year OS of 80% after stopping the Ven-Aza. So stopping Ven-Aza after achieving remission is feasible for newly diagnosed AML patients with a median TFR of about 15 months in this study and an OS of 44 months. MRD negative status is predictive of sustained remission. Coming to the one more interesting data set that I looked at, this is published in the ASTCT journal in a retrospective study of 140 patients were compared with chemo versus Ven-Aza who got a transplant. Patients who got a transplant, irrespective of what they got initially, the PFS and the OS were similar, and patients who got Ven-Aza followed by transplant, even if they were MRD positive prior to transplant, it didn't matter and they did well. So hypomethylating agent and venetoclax are moving up the ladder, and more, even in fit patients, people are tending to use HMA-Ven, and the studies will be published soon looking at this question. And this is our own data from our hospital where we try to look at Ven-Aza versus chemo, and the results look impressive for HMA-Ven-Aza. So concluding, there are a plethora of new drugs for AML for the last few years, which is going to improve outcomes in young and old patients. Shorter turnaround time for NGS is very important to do a state-of-art for AML patients. New genetic classification is important to learn and here is to stay. And better risk stratification tools, MRD evaluation are needed to choose between Ven-Aza and intensive chemotherapy. About 30% of patients achieve long-term remission with HMA-Ven, and treatment-free remission is being considered in AML also. Transplant after HMA-Ven is a viable solution in patients who are unfit for intensive chemotherapy. Thank you.
Very good, Dr. Santhosh. I think you have done a wonderful job in 10 minutes because very difficult to cover each and everything in the 10 minutes. Any one comment or one question? No? Okay. I think there is a wonderful talk because we are moving from 7+3 to adding something. So definitely it's a very good talk. Next, I would like to invite Dr. Rajani Priya. So she's a consultant in Mahatma Gandhi Cancer Institute, Visakhapatnam. So she did her thesis and she published. and she presented a paper in APL in ASCO ASH also. So we would like to invite Dr. Yedla, Rajani, Priya. Okay, go for again just 10 minutes. I think we may be that little time, but we have to finish in time. That's all. Thank you.
Thank you, Sada sir. Thank you for the kind introduction, and thank you, ICON and organizers for giving me this wonderful opportunity. So it's a privilege to be a part of this 50th Golden Jubilee conference. So myself, Dr. Rajani Priya, I'm consultant medical oncologist from Mahatma Gandhi Cancer Hospital. So in the next 10 minutes, I'll be taking you through the success story of APL, which has transformed from a highly fatal malignancy to a highly curable one. So we all know that APML is a distinct entity of AML, which is characterized by a translocation between chromosome 15 and 17, and it accounts to approximately 5 to 20% of the cases. So this is the first paper which was published in 1957 by Hilsted, and he identified that one type of leukemia AML is having a rapid downhill course, which is characterized by very high coagulopathy, and he named it as acute promyelocytic leukemia. It was in 1957. And why we consider APL as a fatal disease? It's mainly because of the two main complications associated with this entity. That is the disseminated intravascular coagulation and the differentiation syndrome. So this is a paper which was published in SAJC. It's from my parent institute, NIMS. So we have analyzed 73 patients with induction failures of almost 22%. And the most common cause of the induction failures in our study is an infection, followed by hemorrhage, which is seen in 37% of patients, and differentiation in 12% of the patients. So if you can see in the paper, almost 78% of patients have achieved CHR, and if we can manage the 22% complication rate, we can cure these patients. And the relapse rates, we have even analyzed the outcomes, and the relapse rates are approximately 7 to 9%. So if patients who can survive the induction, they're almost like cured. So this is an evaluation of APL, how it has transformed from a highly fatal to a highly curable malignancy. So unlike other malignancies, there has been no much progress in the APL, but whatever the changes that had happened in APL, that is the targets, they identified the target, and with the advent of the targeted therapy, now we are able to cure APL. So in the next coming few years, maybe with the availability of the oral arsenic preparations, we will treat APML maybe on OP basis with just oral formulations with ATRA and ATVO, same like a CML. So coming to the journey of the APL, first is the era of the chemotherapy. So previously all the AML patients, like this APML is also treated on par like a AML with anthracyclines and the cytarabine. So this, they observed that this subset of patients are having extreme sensitivity to anthracyclines with the CR rates of 50% and 50% induction failures. So then they even observed that addition of cytarabine to anthracycline had not resulted in improvement in the event-free survival or the CR rates. So then came the era of the ATRA in 1987, where they found that this differentiating agent has improved CR rates. That is, almost 24 patients who had been treated with this ATRA achieved complete remission. So this is other study where 50 patients achieved CR rates of almost 94%. So from 50% of CR rates, we can see with the advent of ATRA, which is a game changer in the management of the APL, the CR rates have almost approached to 95%. But then they realized that even though we are achieving very good CR rates of almost 95 to 100%, they're having relapses when we are treating patients with the ATRA alone. So the relapse rates almost range in various studies from almost 9 to 19%. Then they thought, like, what? If you're treating with anthracyclines alone or we are treating with ATRA alone, we are not able to balance both CR rates and the relapses. Then they tried to combine ATRA with the chemotherapy. So even that was tried in a sequential manner. First ATRA was given and they tried to consolidate with the chemotherapy. And with the IDA regimen, which is a gold standard regimen, they tried to combine ATRA and chemotherapy. And all the randomized studies, they confirmed improved outcomes with ATRA followed by chemotherapy with overall survivals of almost 75 to 80%. And you can see the CR rates are also very good with the use of these ATRA plus chemotherapy. So based on all these studies, ELN established the combination of ATRA plus anthracycline for induction, followed by 2 to 3 courses of anthracycline-based chemotherapy as a standard of care for newly diagnosed APL. Then came the era of the arsenic trioxide. So ATO, it was first tried in the relapse setting. It was in 1988. So of all the patients in the relapse setting, 11 patients who were treated, 8 of them had achieved, 11 patients had CR even relapse setting, and even in other studies in relapse setting, the CR rates are almost 85%, with survivals in the relapse setting almost approaching to 50 to 60%. So then from the relapse setting, ATO made its way into the first line setting. So these are the various studies where ATO was tried in the first line setting, and if you can see, the CR rates are almost about 80 to 90% and even 95% in some studies. If the major landmark study from India, from CMC, that is by Matthews sir, if you can see, the CR rates are almost 85% with the use of only single agent ATO. This is the largest study from India, which was published in JCO by Matthews sir, and even on long-term follow-up, the survivals are almost 75%. So then they thought, like, for a curable malignancy with almost cure rates of almost 75% to 85%, are we over-treating these patients? So are there any subset of patients where we can cut down on chemotherapy and protect them from the long-term side effects, or with the myelosuppression which we give with the chemotherapy? So then came the idea of the risk stratification. So from the joint study of the Jemima and Fatima group, they try to identify some factors which are affecting the prognosis, and they risk stratified the patients, and they divided the patients based on the WBC count and the platelet count into low risk, intermediate risk and high risk. So this is International Consortium APL 2006 study, which we used to follow in our institute previously, where edarubicin, we have major data with the use of edarubicin. So they try to see whether daunorubicin can replace edarubicin in developing countries where cost is an issue. And they have shown that the 2-year DFS and OS of the patients enrolled in this study are comparable with the trials conducted in the developed countries. So this is a landmark trial by Lococo, which entirely changed the treatment of the acute promyelocytic leukemia, where they tried to combine ATO and ATRA. So this, if you can see the 2-year survivals with the use of ATRA and ATO when compared to ATRA plus chemotherapy, which is a standard of care at that point of time, that is the IDA regimen. The survivals, you can see the 2-year survivals are almost 99% in the ATRA ATO group compared to 91% with the ATRA chemotherapy group. So even in the long-term follow-up results, what they have concluded, initially it was started as a non-inferiority trial, but later on long-term they even shown that in low intermediate risk patients, ATO ATRA has fared far superior to the ATRA and chemotherapy group, and it became the standard of care in low intermediate risk group patients. So this is a APML4 study. So this is other study where irrespective of the group, all the patients were treated with the 3 agents, that is ATO, ATRA and chemotherapy. That is, idarubicin was used in the patient. So in induction they have given anthracycline, but in consolidation they tried to cut down the chemotherapy. So in consolidation they are giving only ATRA and ATO based consolidation for 2 cycles, followed by maintenance therapy. So this is a APML4 study, which is another landmark study where they are trying to cut down the chemotherapy. So we are moving from giving chemotherapy to all patients, avoiding chemotherapy in low intermediate risk patients, and even in high risk patients also. So they give chemotherapy only in the induction phase and try to avoid in the consolidation phase. So if you the results of the APML study, they have shown that the overall survival even in the high risk patients is about 75%, and in low risk is 97% and 88% in the intermediate risk. So it's a doable thing, that is avoiding chemotherapy as consolidation and giving chemotherapy only in the induction in the high risk patients. So this is other study where AML 17 study where ATRA ATO was compared with ATRA and chemotherapy, and it has shown to be superior across all risk groups. So in all randomized studies where ATRA and ATO was used in frontline, CR rates are almost 90% with DFS and OS of almost 80 to 90%. So these are the real world data. So this I've already mentioned in the previous slides. Single agent ATO from CMC by Matthew sir. So the survivals are almost 75% with the use of single agent ATO in the frontline setting. So this is a study from NIMS where almost 111 patients we have studied for outcomes. So at a median follow-up of 34 months, the EFS was 69% and overall survival was 75% across all risk groups. In the low intermediate risk group, it was as high as 85%, and in the high risk, it's 62%. So this is a study from AIMS by Bajpai et al. So if you can see the overall survival is 75% from this study. This is also from AIM by Dayama et al. It's 75% overall survival. So overall, even across all Indian studies, we are having survivals of almost 75%. So coming to the relapsed APL setting, so for patients who relapse, we give either we try to, after it in second CR, we try to consolidate with either auto BMT or allogenic BMT. So how do we take a call of whether to go for auto BMT or allogenic BMT? So even in second CR, it's autologous stem cell transplantation is a standard of care for patients who are MRD negative. But if they're refractory and if they're still MRD positive, we have to go for allogenic stem cell transplantation. This is because if you can see the curves, auto BMT is superior to allogenic stem cell transplantation in patients in CR2. So coming to the recent advances, gemtuzumab osagamicin is being used in high-risk APL patients with survivals almost approaching to 85%. So we are trying to improve more and more over in high-risk patients to improve the survivals to almost 85 to 90%. So these are various agents which are being used. So last slide. So this is this was presented in ASH by Gill. So where oral arsenic trioxide was used along with ATRA, and only in selected patients, that is high-risk patients with more than 10,000 counts or young patients with no cardiac comorbids, anthracyclines were given, and they have shown that this is a phase 2 study. So they have shown that the survivals in the study is 97%. So even with oral regimens, we are able to, across all risk groups, so we are able to achieve good survivals in APML. Maybe in future we will even reach that 95-100% even in all risk groups. So these are the emerging targeted therapies. So I'm not going to the detail because of time constraints. So finally, to conclude, at the diagnosis of APML, so this is how we treat in our clinic. All low-risk patients, we treat with ATO and ATRA. For high-risk patients, we give in induction ATO ATRA with anthracycline or gemtuzumab osagamicin for patients who have cardiac comorbids and who can afford for gemtuzumab osagamicin. So in consolidation, we try to avoid anthracyclines and we consolidate only with ATRA and ATO irrespective of the risk. Coming to the maintenance, in low risk, there is no maintenance. In high risk, it's still debated. For patients at the consolidation, if they're MRD negative, then we can avoid, some try to avoid maintenance. But for high risk patients, we still prefer to give maintenance therapy with ATRA 6-MP and MTX for 2 years. And at relapse, we can use either ATO plus IDO or gemtuzumab osagamicin or ATRA and ATO based on what regimen they have received in the first line setting. Even other agents like single agent gemtuzumab and tamibarotene, which is a synthetic retinoid plus ATO. So these are still under trials and evolving. So how to consolidate, this I've already discussed. If they're MRD negative, consolidate with auto stem cell transplantation. If they're MRD positive, consolidate with allogenic stem cell transplantation. Thank you.
Yeah, thank you, Dr. Rajani. I think in the time you have completed the therapy, I think this is one of the highest curable malignancy what we see. So of course, it's a journey from arsenic trioxide, ATRA to now. This risk stratification now, there is no intermediate now, only low risk and high risk, that's all. So in that, I think now, especially in a high-risk patient or gemtuzumab osagamicin, if it is available, you can use this to decrease the WBC count. And only the highly clinical suspicion is important in these cases. If you have a good pathologist, they'll inform us one APML, suspect AML, so immediately we'll take over the cases and we can do the justice too. So we need a good multidisciplinary approach, good pathology, good blood bank support, and at the end of the day, good patient and family support also should be there, definitely highly curable. And sometimes we'll see as a crops of the case, actually. I think all of us, we know that one. We'll see at a time 4 or 5 cases in a ward. We don't know what the reason. I think we try to find out, but we could not find any exact reason for these crops. Okay. Any comment from anyone? One comment. Okay. Thank you, Dr. Rajani. The wonderful talk. I think we'll go to the next panel discussion. So as usual, there were multi-talented person, Dr. Prashant Mehta. I will invite Dr. Prashant. So I think he's the senior most consultant and hemato-oncologist from Faridabad. So he's going to moderate the session. Where are we in managing ALL in 2024? So I'd like to invite all the panel members. Dr. Rakesh Reddy, again he's a senior consultant in Vizag from Apollo. Dr. Madhav Danthala, he's also a consultant and hemato-oncologist and transplant physician from Yashoda Hospitals in Hyderabad. Dr. Pujita Baireddy, she's also from Hyderabad. Vasu Babu, is a medical oncologist from Vijayawada. And Sugit, he's a medical oncologist from Trivandrum. Yeah, I think we missed Bala Sahib. So, over to you, Dr. Prashant now.
Thank you so much, sir, really. Thank you for your invite here for this wonderful meeting. So, this is our expert panel today. The names are flashing on your screens. We're discussing a very heterogeneous disease today, actually, and very complex management. So, the management of ALL in children has been, really rewarding, and the survival has been improving with every decade. And we are at 95% now. Adult, this is the CalGB data, 40% at 3 years, not doing so well. This is again from the Contagion group, MD Anderson, HCVAD, and here you see 40-45% at 5 years. And this is the data from India, that's from Dr. Ganeshan's paper. And you see here EFS 30, 50, 50, much lower than children. So this is a problem area. What are our learning objectives for today? What do you want to do better in 2024? We want to identify a difficult ALL subsets, PH like ALL, the KMT2A type MLL formally, and how we incorporate our newer agents, immunotherapy drugs upfront or at consolidation. Can we reduce chemotherapy for older patients? Can we use novel agents upfront? CAR-T, where is it? Where do we use it? What is the ideal use in India specifically? So this is the classification, and there are some new subsets which have been added in the new WHO. 2016 onwards, we identified this group of KMT2A rearranged and also the PH-like, which were earlier provisional groups. Also, there is an intrachromosomal amplification of 21, which is basically more than 5 copies of RUNX1 detected on fish. And then we have ETPLL in the T subset. So this is one patient scenario which we will discuss today, and we will try to, through this case, we'll try to discuss everything which is possible. Because examples teach us best. So this is a 32 years old lady, IT professional, first OPD visit, very anxious family. This is the blood counts, and the PS showed 80% blast, spleen is enlarged, no definite lymph node enlargement. There was long counseling session in the OPD. The father is a very senior professor in a university hospital, and the flow was sent from peripheral blood. So this is the flow result. It showed ALL. B-cell, a precursor B-cell ALL, and this is the, some of the plots where there was some population of dim to moderate expression of CD19, raised some suspicions, and then, was not looked into further, but yes, keep this in mind for, subsequent discussion. So, my first question to Dr. Pujita, is bone marrow examination always mandatory to diagnose ALL? Yes, no, desirable, but not mandatory.
So for the diagnosis, it's not mandatory, sir.
Okay.
We can send, if the peripheral blood itself is showing adequate number of blasts, we can send the sample.
Fine. So this is the NCC, and it also says that in some situations, emergency situations, if you avoid it, you may actually be okay. But yes, we do try to do it because we now have NGS-based MRD assay. You need to have a baseline bone marrow biopsy in some situations when you're going to send it later. It is right now not available in India, but you want to send it to the US or somewhere, you need to have that baseline tissue. So maybe that could be one reason of doing a bone marrow biopsy. Rakesh, so what do you look for in a flow report in BLL in 2024?
Yeah, so
some questions. What is the significance of all of these?
Yeah, okay. So first is flow should be done as close to the treating institute as possible. That is one thing. We, many of the centers send to these centers far away, and you'll get cells with degeneration and all those things. It's very important to have a fresh sample, analyzed very early, 8-color flow cytometry. That is,
answer the question on your screen.
Yeah. So CD20 expression, I think it is there in about 20-25% of ALL. So yeah, the expression is important. It suggests some therapeutic relevance also. Rituximab, CD22 obviously with inotuzumab, CD19 for CAR-T as well as blinatumomab, CD38. Not very sure daratumumab data is coming up. the last I couldn't actually see, but I think CD10 negativity correlates with KMT2A rearrangement,
So
and
some
CD13, 33, 66 will correlate with pH positive.
Absolutely. So some data from flow can actually guide genomics also. Tell us, give us some idea. What are the high risk features in adults, Dr. Madhav?
So high risk features in adult BALL, adult BALLs by itself, they have a higher chance of pH positivity, and that's one risk factor. Also the pH-like signature as well. And the traditional risk factors, in admission, white cell count and all these with...
So those are on your screen.
Not that important now, I would say.
That's okay. So there's some clinical high risk factors. Genomic risk is defined by some of the mutations. Some of the new ones are DUX4, PAX5, PATR, a long list actually. Then in the poor risk, they've added MEF2D and ZNF384. All these are new ones. pH-like obviously there. Yes, you're right. Dr. Vasu, what is mandatory at baseline? What all out of all these tests? A, B, C, D, E, F. What would you choose? Some issues with the mics. Yeah.
For me, all except NGS. I advise NGS and RNA sequencing only if the typical FISH panel is negative.
Understood. So you're choosing F?
F. Yes.
F is okay for you?
F is okay.
Okay, fine. Fair enough. But you want to do for most, okay?
Yeah, all adults FISH
all adults,
negative.
Okay.
FISH negative.
Understood. So, how does the age influence, Dr. Vasu? What mutations? If you want to choose some panels based on the age, what would you do? pH-like for which subset?
pH-like for typically, if you took into clinical factors, older children, low WBC count, and FISH negative. The typical screening for pH-like analysis, FISH negative, typical AL.
So, in the older adults, you find it more?
Yeah, older adults. Yeah.
Fine. So then there are, classically you see the, more favorable mutations, like hyperdiploidy, more in children, and in adults you would find the unfavorable factors, more pH-like, and more CRLF2, all of that would be there. IKZF, you would find more in adults. pH-like AL, how do you define, Dr. Pujita?
So, sir, these patients have other mutations which have the EPOR receptor translocations.
So basically the gene expression is similar to pH but not BCR-ABL. Some others. What are those others?
IKZF1 mutations, CRLF2.
What is IKZF plus?
I'm not
Alongside IKZF you have some other mutations. Rakesh, you would like to comment on that?
So majority 50% of pH positive like AL will have CRLF2 and the related this thing, and the other are ABL1, ABL2, IKZF, and IKZF is Icarus zinc finger lymphoid transcription factor rearrangements. So these are the common pH positive.
So you're right. So if you have CDK N2A, N2B, and you have PAX8 or PAR1 alongside IKZF, it is IKZF plus. So that is actually truly high risk in the absence of ERG deletion. All these are commonly common situations. pH-like, how do you work up? Rakesh, you can carry on.
Yeah. So the easiest thing, like some of the centers has developed, is a CRLF2 flow, which identifies almost 50% of pH-like ALL. Because we don't have, I have not seen such kind of reporting. So probably you have to send for specific analysis. Ideally, it has to be a gene expression profiling, because we don't have that as commonly. We can look for certain abnormalities on NGS and can arrive at a possible conclusion that it is likely a pH like ALL.
Absolutely. So this is a simple flowchart. They are JAK-like and then the ABL-like. So 50% and 50% each. CRLF2 overexpression on flow is a very easy way to pick up a large subset of pH-like ALLs. So CRLF2 subgroup actually does worse. There is data to that effect. You can see the survival curves here. This is some data from MD Anderson where a protocol like HCVD was actually able to negate the effect of having pH-like to an extent. So these curves with HCVD enoblina, they were better in the pH-like subset. The median PFS was longer. So this is another question for Dr. Vasu. How do you test for IAM21? When to test? Or you do for everyone?
Yeah, not for everyone. So I am only if the patient older children and low WBC count, and we detect by fish.
Absolutely.
So fish, if detects more than 5 copies of RNX1 in chromosome 21.
So very important point, you don't test it for everyone. You test for some subsets, which you mentioned on the slide here. So how do you risk stratify pH positive? Dr. Madhav, are all pH positives the same or different?
So it is a heterogeneous subset, like you had mentioned. Some ABL class fusions are different. Those with Ikazarov are different, and the CRLF CRLF are different.
Yeah.
Again, the treatment also depending upon if the JAK is involved. So treatment is decided based on each of these categorizations.
Absolutely. So IKZF is the actually mutation which actually is the most important. IKZF plus, very common in pH, like maybe 3/4. If you have IKZF driven pH like ALL, pH ALL, then you have it is called high risk. Also, if you have underlying CML, that's also a high risk factor. So this are the two situations where it's high risk pH positivity. Otherwise, it's taken as standard risk. And this is the data to that effect. This is the IKZF1 driven low risk and high risk. So based on whether it's IKZF plus or not. So you test for TKD mutations in all pH positive ALLs, Dr. Balasab. Does it make any sense, or is there something which Dr. Balasab is not there?
So at baseline, the pH positive ALLs have a higher incidence of these mutations compared to, like you would say, in CML. So
and there are some drugs which are actually we cannot use.
Yes. So it makes sense to test it at diagnosis.
It makes sense to test, and some drugs will not work, and they're contraindicated in NCCN. So if you use it medically also, there is a problem. So we have to choose our TKIs carefully. Imatinib, many mutations are actually contraindicated. So imatinib in pH positive ALL is a problem nowadays. So what about DUX4, Dr. Pujata? How is it different from other ALLs?
Sir, it is also associated with, it's a new entity, relatively new entity, and it is associated with young adolescent group and also associated with bad prognosis like PH, like ALL.
DUX4?
Sorry, sir?
DUX4. It's a
good
so that shows ALL is very complex now. So DUX4 has a favorable
I don't
prognosis.
think all centers do this.
They don't do it, yes. So, but there are some surrogates. ERG deletion is a surrogate for DUX4, and if you have ERG deletion, so it makes it good prognosis, and also IKZF deletion, even if it's present with DUX4, it's still favorable. So it's one subset, a small subset, which is a favorable prognosis. Also, a very important CD marker is CD371. This actually correlates with DUX4 rearrangement, and this actually can be followed for MRD assessment also. So everybody who is 371 positive, the MRD protocol needs to incorporate 371 always. So that's kind of a dictum. So these are 4 major types of ALL now from all this discussion in the clinic: pH positive, pH like, CD20 positive, which is also kind of a unfavorable factor, but some of these actually still standard risk. And then the newer categories like DUX4R. So is there a role of germline testing in ALL, Dr. Sugit?
Routinely, I think most of us don't do the germline testing, but it is mainly to identify the familial syndromes. At least we know the TP53 mutation.
Can you tell me one situation where it's absolutely mandatory to do germline testing for a particular mutation?
Is it the RUNX one?
Rakesh? Any one situation?
No, nothing that comes to mind.
So it's a hyperdiploid ALL where TP53 germline is common. So if you're high VAF for TP53, you need to do germline TP53. So because that is one situation. And some other situations are mentioned on your screen. So molecular workup was done for this particular patient in question. It was not pH-like, not pH, no high-risk anomalies, overall pre-BCL ALL. What is your treatment of choice? Dr. Sugit, Dr. Reddy, and Dr. Vanway in sequence.
For us, we usually use the BFM-based protocol and both hyper-CVAD.
Okay.
And especially for the ETP ALL, we use the hyper-CVAD. Otherwise, for the standard risk BALL, we use the BFM.
Use BFM type backbone. Any other, deviations from that? Okay. So this is the data, on survival with pediatric versus adult-inspired, treatments. And if you use a pediatric-inspired regimen, you have a better chance of survival. So this is ages 16 to 20 in various countries. So it is the way to go for this particular subset. So if you use the pediatric versus adult, the difference you see, the difference actually intensifies as the, in the IR subgroup. But in the older population, the difference actually narrows down, 14%, 11%, and by the age of 45, it kind of vanishes. So, this is that slide depicting that difference between, adult versus pediatric inspired protocols. Upfront treatment, can it be less intensive for some of the patients? Dr. Pujita, are there ways to decrease the toxicity?
If in case of pH positive ALL, we'll try to de-intensify the induction therapy by omitting the asparaginase as well as the doses of daunorubicin. Even if it is unfit and elderly patient, nowadays we are trying to use mini hypercVAD plus inotuzumab combinations.
So that's Blina and incorporation upfront in the older patients is kind of making waves, and it's becoming the norm. So these are some of the data sets where it has been actually, this strategy has been used, and when the pH positive Blina, Puna, Blina, Dasa have been tested, very good effect. So Blina upfront, the panelists, do you want to use upfront Blina now more and more, or the availability issues and
availability and the cumbersome process of giving the drug is
we have used in 5 patients till now. We don't have a huge experience with using it, but those 5, I found it very comfortable somehow. There is no toxicity at all. There was one patient who had seizure and did one episode, and then we kind of treated it and we continued. If you have a second episode of seizure, you have to stop it completely.
I personally don't have Blina experience, or only inotuzumab upfront we have used.
So that's how I think the field is moving. So Blina incorporation upfront may come into the upfront arena, because maybe we have it available in India sometime. I don't know when. So the journey of our patient continues. The time point 1 MRD with the BFM type induction was 0.01% and NGF was 0.003%. There was also this strange kind of clone which was actually ignored in this data set, but it assumed significance later. It was at 0.095%, and this was kind of a dim CD10 clone, and different from the routine clones, and they thought it could be some hematogone or some artifact or something, but they mentioned it in the report. It was kind of slightly, not very clear about it. So, what is NGF, Dr. Pujita?
Sir,
how has it changed the management?
I mean, they use more multicolored panel will be there.
So some differences are there from the usual flow. They use more colors, 8 to 12, and they acquire a very high number of cells, more than 5 million, to achieve a deeper sensitivity, sometimes as good as NGS platforms, and 10⁻⁶. And data analysis also with some novel analytical tools. Dr. Nupur in our center, she actually taught us more about NGF, and this slide was actually made by her only. So what next? You have these results. Should you continue the protocol? You want to do something else?
MRD negative, so we'll like to continue. You
would like to continue, okay. Continued. I followed your instructions. So MRD 0.01% after 1B and 0.005 on NGF. You would like to do something different or continue the same?
Continue same.
Continue same, okay. So did we do the MRD right, or we should have done something different? Ready?
So provided the marrow is of good cellularity, then I think this is what we have in access, and that is what is readily reproducible across the centers.
Okay.
So I am happy with the flow of the marrow, and for all other quantitative parameters, the amount of cells analyzed.
What about NGS? Should we try doing NGS in such cases?
NGS is not standardized. At least I don't know any Indian center which has NGS.
So not in India. It is in the US by a company called Clonoseq.
We are going to send
the cost of doing the first Clonoseq.
4.5
lakh.
Yes, absolutely.
Very difficult to do.
Yes. So
but just for the awareness of our audience. So role of Blina in MRD negative. Is there some role?
Yeah, there is ECOG-ACRIN data.
ECOG-ACRIN 1910, very famous trial. They have incorporated 4 cycles of Blina. What happened? What happened there?
Benefit. There is OS benefit.
OS benefit, yeah. So OS benefit is what we look for always. So Blina plus chemo in the BFM backbone, 4 cycles, it showed an OS in the MRD negative population. But there was one caveat, not in the more than 55 years, and also people who got less than, or got less cycles, 1 or 2 cycles, they did not benefit. So the people actually who benefited were those who got 4 cycles. So that's also because we sometimes practice just 1 or 2 cycles. So that's an issue with our approach. So what if this lady was 65 years? What different would you have done?
So first is the early mortalities. That's a big issue. The poor performance status and obviously the organ status. So I would definitely de-intensify chemo and try to see if we can do something like mini HCVD plus inotuzumab.
What you said is on the screen now.
Yeah.
So mini HCVD, you know, this again Dr. Kandarian's, Dr. Nitin Jain's group, and they have used very innovatively. They have used lower doses of inotuzumab. Just 2 doses per cycle of mini HCVD, and they have shown that they can have very good outcomes. Early deaths were 0, and the long-term data from HCVD Blina is at about 40% at long-term follow-up without early mortality. In the IA subgroup, it's about at 60%. So this is the PFS-OS curves there. So rituximab, does it have a place in ALL? Dr. Madhav.
CD20 was positive at diagnosis, so that is a
for this patient, it was negative. But generally, I'm asking, does this patient merit or not? This patient CD20 was negative.
Okay, this patient it doesn't.
Negative. It does not.
I'm talking about the previous patient
Does
who
or
had
does
CD20.
not? There is only one patient in this.
So if this patient CD20 negative, then no retux.
No retux, okay.
Irrespective of CD20.
So what cutoff of CD20 should be there? Like
It is 20%.
20%?
20.
1%? 0?
It's 20.
Okay. So there is data from UKLL 14 where they have given to everybody irrespective of CD20 or not, even in the negative. And they gave only 4 doses, and they found that there is some difference, but it was not significant though. In GRAL trial, there were 16 doses, but when you talk to some of colleagues outside who are using rituximab outside India, they're saying that any expression is okay, and steroids actually upregulate the CD20 expression. So any expression, 1% onwards, it's becoming a norm to use rituximab. Pegosparaginase, a difficult drug to handle. So how do you handle it?
So asparaginase, previously we used to give the conventional. By that time it was up to the age of 40. Now we are using the L-asparaginase, the pegylated L-asparaginase. So we usually give for the adolescent and young adults till 40.
So how do you modify your protocol for your adult patients in IA? So what do you check up front?
Yeah, first,
do you check something?
So baseline, we will definitely, before starting since it is in the induction, anyway we will do the liver function.
Yes, absolutely.
And
so you do liver scans also, and for obese and fatty liver patients, do you reduce the dose? So that's what is recommended also, to 500 units per meter square for pegosparaginase. No hepatotoxic drugs like Premolute, norethistron, azoles, all these are problem. The doses we keep at 1000 units per meter square for most patients, So toxicities, this is a table of toxicities with the various drugs in induction and now consolidation, the immunotherapy. Blina, new drug, neurotoxicity, ICANS. We also chart the handwriting every day like we do for CAR-T, for Blina. Inotuzumab, VOD, so we maintain a gap of 6 to 8 weeks between transplant, and we had a discussion with Vasu. I had a discussion with Vasu yesterday. So we're discussing the same, that when you use HCVD, that risk is slightly less. So you could actually go ahead with 4 weeks probably. This patient actually continued consolidation, but we added Blina because of the ECOG-Acrine 1910 data. NGF was done, but there was this new clone which we actually could not decipher at the outset. This was a CD19 negative clone. I messaged my pathologist in the morning, okay, I've given Blina to the patient. Please look for a CD19 negative clone. And she found one, and this clone actually had not disappeared. The CD19 positive had disappeared. This was at 0.095%, which is a cutoff for high risk or a transplant. So thereafter, coming to this, MRD is the only thing actually which matters in BLL. Is it the only thing, Rakesh? Yes. Yeah. So what does MRD mean? The deeper level of remission you have, the lesser is the chance of relapse. It could actually be a continuous variable rather than a categorical. So, and there are some situations where even any measurable residual disease could actually be a harbinger of an earlier relapse. So there are so many techniques to do it. Conventional flow cytometry 10⁻⁴ sensitivity. With NGF maybe 10⁻⁵ to -6, and with NGS you have more than a 10⁻⁶ sensitivity. So this is, so data from a meta-analysis of thousands of patients in pediatric, 11,000, adult, 2,000 patients. MRD actually across is a risk factor for bad outcomes. And also irrespective of the technique used, and also at various time points, having MRD, various cutoffs, 0.01, 0.1, whichever cutoff, it is actually, unfavorable. So how do you ideally test for flow-based MRD? How do you, pull your sample out? Is there something different from usual doing an aspirator usually?
Yeah, I think first we have to assess the cellularity of the marrow.
No, when you do
it's the
procedure,
first sample. Yeah, it's the first draw.
First
that you
pull.
do.
So
First
less than
draw.
3 ml.
Yes.
Yeah. So that's a norm. So and you try to acquire more than 5 million events, as in the NGF slide it was mentioned. So MRD is actually better, risk stratification tool than any gene, any genetic mutation. So if you transplant based on MRD, you will be curing more patients. But even for mutations like IKZF plus or the other high risk, so many, the long list of mutations, there is no data that transplant actually improves survival as of now, even for the IKZF plus. So MRD is actually the real tool here. So we need to, in India, we need to improve how we test our MRD. That should be paramount. So in the MRD positive, Blina has a role. We give consolidation Blina, and you can actually convert some of these patients from MRD positive to negative. And then when you transplant them, you can achieve better survival. Leaving them at Blina also, does not give optimal outcomes. So who to allograft in CR1? Rakesh.
So obviously MRD positive. And once they achieve the MRD negativity with any salvage regimen, there are...
How do you decide your time point? Which time point MRD positive is important?
So TP1 MRD is still important. It will give us an indication of how the patient is going to, but my action of time point will be the end of consolidation.
End of consolidation. So that's the most commonly used time point. End of consolidation, any particular reason you want to slightly choose your later time point? Any particular specific reason? So would you want to expose them to anything before you transplant?
There is concept of dynamics of response. Early responders do well, but there are certain lineages or certain subsets which do
you
pick
have
up.
a concern that if you transplant earlier, you have not adequately addressed the CNS?
Yes,
or you're not
the methotrexate part that gets missed. Yeah.
So, makes sense to give that also in some patients, if they are, not a very high, degree of disease. So CR1, if you transplant everybody, all adults, you are not likely to get a better survival. So you have to choose based on MRD. So if you transplant everybody, you see the allo curve actually is lower, and the NRM is also higher with doing an allo. So you should not transplant everybody blindly. It's a very nuanced discussion and a very not so easy to choose your transplant candidates. So this is the, from NCCN, even for patients who are MRD positive, and there's insufficient evidence to suggest a survival advantage of HCT, even with IKZF1 or these bad type of mutations, PH-like, or IAM21 also. So there is no data to transplant these patients. You need to do your MRD well, and early responders are the ones which can be probably spared. So now, because there can be no talk complete without a mention of CAR-Ts, so I would just ask one question about CAR. So which of these following statements are not true about Tisacel and Eliana? Anybody can answer. RFS 44% at 5 years, 14% transplanted. Median RFS was 12 months. Median blast count was 74%.
Not true.
It's a slightly difficult one, I understand. But yes, it's the RFS was 40 months, 42 months, so that's incorrect, but others are correct. So that gives some information from the study there, which is the kind of landmark study for CAR-D in ALL. Indications for Indian CARs as of now in BALL. Rakesh.
Yeah, so refractory ALL, relapse post-allotransplant.
Can it replace transplant, Rakesh?
No, it wouldn't replace transplant as of now, no.
Right now, no. But this subset from Eliana, where patients who are clonoSEQ negative, we don't have the infra right now to decide not transplanting these patients. But when we have that, that seems long way away in the future, but right now we can't say that they should not be transplanted. So this patient was continued intensification. We followed weekly PBMRD, and we watched the disappearance of the second clone, which came out in the later flow cytometry, and then she has been haplografted, MRD negative, and we have planned clonoSEQ for this patient. She is doing well at day 90. So my take home, MRD, and it can be a continuous variable rather than a categorical. We need to probably do more and have better validated tests in the country. That's how we probably would be able to improve our outcomes. And the HSCT MRD, pre-HSCT, like the continuous, the relapse rate is a continuous function based on the MRD you have pre-HSCT. So this curve shows that. And this, I love this slide from Dr. Ganeshan's paper, When to allograft, your center-specific TRM also comes into the picture, and these are the factors you could consider when discussing transplant with a family where there is, who has a patient with ALL. So thank you. Any closing comments? Oh, difficult question. I did it because I could not do weekly marrows, and I wanted to understand whether this is a chemo-refractory clone. So I need to use INO, or I can just continue with chemotherapy. That's why I did it.
Did not use INO?
I did not use INO because I wanted to keep it for relapse later, and I did not want to delay the transplant. If I had used INO, I would need to delay the transplant. And also, I would just not have another option later because this is a CD19 negative clone. CAR-T is not an option, BINA is not an option. So that's how.
The very last slide that you showed, the slide, Dr. Ganeshan's pH positive ALL is recommended as a setting for strongly considering allotransplant. I don't think that is.
Yeah, the NCCN right now says that all pH positives are standard risk unless they have IQZ plus or they have underlying CML. So.
Yeah, very good discussion. I think Prashant and all the panel members, they did a wonderful discussion, especially this next generation. I think people who are practicing in something like in a government hospitals, I think something like it is a different context, but I think we have to update our knowledge in all these monoclonal antibodies and CAR-T therapies. I think where we are working in our area is, I think the patient has come with something like in a WBC count initially something around 70,000. Within 3 days, because of thrombocytopenia, somebody will start some steroids. The fellow will come with something 3,000 WBC count. We don't know what was the situation at that point of time. We do bone marrow, we do something, they'll say, no blast. So I think there is a situation where, of course,
Vamshi gave me a difficult toy. He said in 2024. Then I thought I will.
So there is all that blast, especially lymphoblast will disappear from the periphery as well as from the bone marrow also. There is a confusion. So what to do again? We'll wait for 1 week, 2 weeks to again regenerate the blast. Again we'll do the bone marrow. Some people will work in a situation where the different context. But of course, always we have to do justice for patient. Try to use the best technologies to what you can say phenotyping, what a risk stratification, either it is a morphological or genetical. Do the risk stratification. Most of our ALLs are curable malignancies nowadays, what we thought. So they should not live with the complications of our chemotherapy. So based on risk stratification, we can de-escalate the therapy, or if the patient is a high risk, we have to escalate therapy to achieve the maximum response or maximum outcomes without any long-term toxicity. That's our goal. So any other comments from any of the seniors? No? Okay, I think.
Thank you.
So now I think we'll move from acute leukemias to the chronic leukemia now. So, photograph. Yeah, Rakesh. I am chairperson. I'm not the active member. Okay, thank you. Now we'll go to the chronic myeloid leukemias. Chronic leukemias, I'd like to invite Dr. Linu Jacob. So he's the professor and HOD from Kidwai Memorial Hospital. So he's going to talk on managing resistant CML in the real world, a challenge and options in India at this point of time. Dr. Linu.
Yeah, thank you, Chairperson. Happy to be part of the Golden Jubilee 50th Icon. Thank you to the organizers for giving me this opportunity. So we'll move from a complicated topic to, I think, probably a favorite topic of everyone. So I'll be speaking about managing resistant CML in the real world, the challenges and options before us. So the outline of my talk will be as follows. First, we will find out what is a resistant CML, what is the definition, what is the prevalence, what are the mechanisms underlying resistant CML, what are the options before us, and what are the challenges. So if you see, as this may be more applicable to the Western world, the life expectancy of patients with chronic myeloid leukemia approaches the life expectancy of the general population. So irrespective of the age, you can see the age being 55 years, above 55 years, even up to the age of 85 years. What they have seen is that the life expectancy of the patients with chronic myeloid leukemia is similar to that of the general population. So as far as Western countries are concerned, the current focus of the CML management is quality of life, maintenance of the quality of life, avoidance of long-term toxicities from the treatment, and probably maximizing the treatment-free remission. So this is because, as I showed in the previous slide, the survival is close to the age-matched individuals. As far as resource-poor countries like ours are concerned, the current focus, even now, the focus is on improving survival, and this is because of limited accessibility to effective drugs as well as effective monitoring. So what is TKI resistance? So it could be primary resistance. The primary resistance happens, or we tell that the patient is primarily resistant when the patient fails to achieve the predefined milestones. And secondary response is a scenario where the patient has achieved the milestones, but subsequently there is a lack of a response. So what exactly constitutes the TKI resistance? So this is fairly very well defined in the ELN guidelines. As you can see, if the patient has got more than 10% BCR-ABL on the international scale, that constitutes failure. So at 3 months, we don't consider it as a failure. At 3 months, if it is more than 10%, you are supposed to confirm it a month later or 3 months later by repeating the BCR-ABL. And if it continues to be more than 10%, again, it's failure. At 12 months, more than 1%. So if the patient is able to achieve a complete cytogenetic response, the surrogate marker for which is BCR-ABL of less than 1%, then you can be happy. So the complete cytogenetic response is probably the most important factor which predicts the long-term survival. So what constitutes resistance of failure? More than 10% at 6 months or beyond, more than 1% at 12 months or beyond, and at any time if it is more than 1%. So then why we talk about the various milestones to be achieved, especially we know that we want it to be, and I told that probably one of the important milestones would be a complete cytogenetic response or less than 1% rather than a major molecular response of 0.1% or the deep molecular responses which we keep on speaking. So the most important milestone which is probably associated with the superior survival, as I told, is a complete cytogenetic response or a BCR-ABL less than 1%. The importance of others lies that if you are able to achieve an MMR, that is associated with increased chance of achieving a DMR or a deep molecular response. And if you achieve a deep molecular response, then you are likely candidate for the treatment-free remission. So that is the importance of the other milestones. What is the prevalence of resistance? So if you see most of the studies, the registrational studies, the Decision and Estent before, we can see that the failure as a result of the efficacy is to the tune of around 10%. So even the literature also, if you see, primary resistance is to the tune of around 10% and secondary resistance is to the tune of around approximately 30%. So here you can see in the dasatinib, at 2 years, approximately 9% of the patients failed. In nilotinib also, it's approximately 9%, bosutinib 5%. So roughly around 10%, and secondary resistance, as I told it, to the tune of around 30%. So the failure rates increase in later lines of therapy. So here the failure includes both the primary as well as the secondary resistance. So you can see that when you start with imatinib, it's approximately 31% will fail. And out of the 31% of the patients whom you put on the second line therapy, 50% of the patients will not respond. And from there, when you give third line a TKI, approximately 75% of the patients do not respond. So ultimately, the failure rate is to the tune of around 12%. And with second generation TKI, it is less than 10%. What are the causes of failure? Always make it a point that you rule out non-compliance before confirming resistance. So all failures are not because of resistance. Failure can be because of the non-compliance, and non-compliance can be as a result of many factors like cost, side effects, or lack of knowledge. So adherence is important, especially in a therapy like CML, where you need to give lifelong treatment. And it has been very clearly shown in clinical trials of CML therapies that adherence is strongly correlated with long-term response. Mechanisms of resistance, the most important mechanism is the BCR-ABL kinase domain mutations. And in CP, it accounts for approximately 1/3 of cases of resistance, and in the advanced phases, approximately 2/3. The other mechanisms being clonal evolution and activation of the BCR-ABL independent pathways.
So management of resistance, when you do not achieve the optimal milestones, or if you fail that the patient has a resistance, so what do? You need to do a bone marrow examination to make sure that the patient has not progressed. Then you need to do a BCR-ABL kinase domain mutation analysis. And again, once again, important is that you assess the treatment adherence and drug-drug interactions before confirming TKI resistance. How do you detect the BCR-ABL mutations? I think most of the centers use Sanger sequencing. Of course, NGS is better. The sensitivity is better than Sanger sequencing. And remember that in 2/3 of the CP patients and 1/3 of the advanced phase patients, mutations cannot be detected. And especially in patients who are failing to TKIs, it is better that you do the BCR-ABL IRMA, that is imatinib resistant mutation analysis using NGS method. So this is the mutation analysis, Indian experience, multiple centers. I think you can see the reports from south, west, north, as well as east. The kinase domain mutation positivity ranges somewhere between 20 to 50%, but more or less if you see majority of the centers, it is approximately to the tune of 30%. And some of these studies have reported the failure rates also. You can see that is also to the tune of around 10 to 12% as reported in the Western literature. So what are the strategies to overcome resistance? Either you can increase the dose of TKI. This is something which we used to use previously before the availability of the second generation and the third generation TKIs, and probably which we are no more using. The other thing is we can change the TKI into a second generation TKI or a third generation TKI or asciminib. The other options being allo stem cell transplantation and targeted combinations, which we will see in the subsequent slides. Second line TKI, select the TKI based on mutation profile and sensitivity. So in the absence of a BCR-ABL kinase domain mutation, there is no clear recommendation for any particular second generation TKI. And we don't have any studies comparing the TKI with each other. So we need to choose the right TKI based on the age, comorbidities, and the toxicity of the first generation TKI. And what are the expected milestones? Here also the expected milestones are similar to that of the first line TKI, which we have already seen in the ELN guidelines. So this, I think it was projected in the previous presentation as well. Some of the mutations were the particular TKIs are contraindicated. So this slide was put just to show that the response rates are pretty much the same with all the second generation TKIs. So beyond second line, what do you do? So you have started on first generation failure, second generation failure. So here also it is to be guided by the sensitivity profile of the BCR-ABL kinase domain mutations if possible. And failure to one or more second generation TKI can rarely be salvaged by another second generation TKI. So even though the approval, if you see for the third generation TKIs as well as asciminib, is when they have failed at least 2 lines of TKI, keep in mind that if you have already used a second generation TKI and the patient has failed, it's highly unlikely that the patient will respond to another second generation TKI until and unless there is a specific kinase domain mutation. So in such cases, the ponatinib, asciminib are the options. T315I mutation also, ponatinib and asciminib are the options. Always consider allo stem cell transplantation. And here in the third line, the acceptable response is a BCR-ABL of less than 1%. So here is the comparative efficacy of the third line. Very clearly, as I told, you can see that the efficacy is better with ponatinib when you use post the second generation TKIs rather than using a third second generation TKI. What about asciminib versus ponatinib? We don't have any direct randomized controlled trials which is comparing asciminib and ponatinib. So you have only indirect conclusions which you can gain from the asciminib, the ASSEMBLE study as well as the OPTIC trial. I think I have the slide. So the gist of it is that the response rates are pretty much the same, but the ponatinib seems to be more efficacious, whereas the side effect profile, especially the arterial occlusive events, are much higher with or almost double with ponatinib. So in such a scenario, what we can probably do is that if the disease, as I told, the potency wise, ponatinib is much better than asciminib. So if it is a really refractory disease, like a primary refractory disease, or if the patient has developed a kinase domain mutation or treatment failure, in such situations, ponatinib may be preferred over asciminib. Whereas it is only because of a failure to achieve the optimal milestones, maybe you can use a lesser effective or a lesser potent drug like asciminib. And cardiovascular events always to be kept in mind. If low cardiovascular risk events, then maybe ponatinib may be preferred. And if the patient is having high cardiovascular risk, you would prefer asciminib over ponatinib. Is stem cell transplantation a good option for CML patients failing second-line TKI? So rather than putting the patient on a third-generation TKI or a non-ATP competitive drug like asciminib, should we directly take them up for stem cell transplantation? It's not a good option, as you can see from in CP patients. In fact, ponatinib did better than stem cell transplantation. So probably you can reserve the stem cell transplantation for a ponatinib failure, or if the patient has failed at least 3 lines of TKI. So this shows the summary of the sequencing, as I have told. Probably in the 3rd line and post 2nd generation TKI, it is better to use ponatinib or asciminib, and probably consider stem cell transplantation for TKI failures beyond 3rd line. Now, once in a while, you will come across a scenario where you don't have any of these options. In such scenario, always it's important that you continue the same TKI even in the absence of a cytogenetic response. So I think the cost of most of the 2nd generation TKIs have come down now. So this is not a problem probably now. We used to face it previously. So in such scenarios, you shouldn't stop. At least if there is a hematological response which is maintained, then the TKI has to be continued, and this will confer a survival advantage. And there are no systematic studies to explain this. And the other options which we always used to do was combining with chemotherapy agents like low-dose Ara-C, or even now we have the option of combining with venetoclax or hypomethylating agents. Targeted combinations are something which are coming up. Combination of an ATP competitive versus a non-ATP competitive ABL inhibitor, like a combination of asciminib and imatinib, or dasatinib, or asciminib with nilotinib. Combination with the drugs which are targeting the non-BCR ABL dependent pathways, the pioglitazone, ruxolitinib, which is a JAK2 inhibitor, and other combinations. So this was a study which we did at our center by combining imatinib with pioglitazone. So again, at a point of time when we did not have the option of the 2nd generation TKIs, and what we could find is that by adding pioglitazone to imatinib, we could increase the response by approximately 80%. So BCR-ABL response improved in approximately 80% of the patients, and approximately 30% of the patients we were able to achieve a major molecular response. So this already I've told when to consider allogeneic stem cell transplant in CP1 if the disease is resistant to or intolerant to multiple TKIs. A rare patient with an inadequate recovery of normal hematopoiesis, again something which we come across once in a while, and probably in a resource-poor country like ours, we may think of it. There are many advocates for allogenic stem cell transplantation. Remember that allo-SCT was once the most important indication for chronic myeloid leukemia. So one-time expense more economical than lifelong drug costs. In CP2, of course, CML progressing to AP and BP, and CML presenting in BP, that is primary blast phase, or a primary AP with a suboptimal response to TKI are the indications for allo stem cell transplantation. So challenges before us: promoting adherence, making available reliable and affordable testing, and ensuring accessibility to effective and affordable drugs, and engaging the patient in decision making. Sometimes it is difficult to make the patient understand that you need to change the TKI. The patient will tell, I am fine, my blood counts are also normal, why are you telling me to change the TKI? So it's important that you engage the patients as well. So summary, the next steps to improve the patient outcomes: select treatment well, monitor adherence, promptly manage toxicities, monitor effectively, change treatment when necessary, and also engaging patients in decision making. So thank you for the patient listening.
Thank you, Dr. Linu. I think you have finished 2 seconds before I had time. I think, okay, so very good. I think this is one disease, I think we have seen a sea change in the management of chronic myeloid leukemia. Once upon a time, we used to think different. Now I think we have 2nd generation, 3rd generation. But only problem here is, again, the 2nd generation TKIs we started using just 10 years ago. Now we started seeing the long-term complications of 2nd generation TKI, especially dasatinib and nilotinib. I think last month I have seen 3 CVAs, cerebrovascular accidents. So I think that even though we have some good drugs, but they have their own side effects. I think that way go, maybe I think like an acute leukemia gives some induction therapy with a good dosage. de-escalate therapy when the patient is not getting. Maybe in the, for example, in ponatinib study, they did the same thing. 45 mg initially. Once you achieve something, major marker remission, they decrease the dose to 15 mg. The patients are doing well. Maybe in the future, I think we have to escalate, de-escalate therapy. Definitely we can do better. And ultimately, our goal is TFR in CML. Of course, any other doubts, any other comments on this topic?
So let's hope that in future we will also be discussing about the toxicities and TFR rather than survival.
Yeah, so I think the next topic again. But one more option, I think, this resistance, I think what we used to do in the past, we did not have the second generation TKI, we used to hike the dose. Imatinib 600 mg and 800 mg. At least we publish our data, more than 50% they achieved CCR with the dose hike. Still they are on the 600 mg of dosage. So I think that's one of the options, but of course we we don't want to discuss at this point of time because of we have available some second generation TKIs are available at this point of time. Thank you, Dr. Linu for a wonderful talk and exposition. And now, to avoid all these complications, now we are thinking of TFR, treatment-free remission. So that I think none other than Sir Hemant Malhotra, sir. I think he doesn't need any introduction, but so CML means in India means I think Hemant Malhotra, sir. There is no other term we can use, sir. Over to you, sir.
Thank you very much, Sada. Appreciate those comments, and thank you, Linu, for a beautiful, platform setting. I removed the platform, by the way. Platform setting talk. Thank you very much. So, ladies and gentlemen, greetings from my cancer center in Jaipur. Very happy to tell you that our first batch of DM students, 2 students have passed out, and we've done 50 transplants in the last 1 month, completed 50. So, most sincere thanks to the organizers of this meeting, the gentleman shown on this slide, for this opportunity. And they were just showing the whole album of all the icons, the 50 icons which have been done till now, and I'm happy to tell you that I've attended about 40 of those. So for the newly diagnosed patient of CML today, all of you would agree with me that all these are legitimate goals. We want an early and deep response. We want a complete cytogenetic response, complete molecular response, so that we have a better PFS, event-free survival, and an overall survival. We want no patients, 0 patients to go to accelerated phase or blast phase. We want no patient to develop kinase mutation or any other mutations. We want to maintain their quality of life so that they can be productive citizens of this country. And we want to cure these patients. We want them to be in remission even after stopping our TKI. So that is what is known as treatment-free remissions. When these TKIs came into the market some 20 years back, I think Sada would remember that, Govind would remember that, I very distinctly remember that. We used to tell our patients, you will have to take the drug for life. But now, this concept of TFR has come, and this is what I'm going to elaborate on today. So why should TFR be the goal for all newly diagnosed patients, particularly the patients who are young? And this is the kinogram of the various TKIs which we use. And I don't know whether my pointer will show there or not. So the first red blob on the left side is the BCR-ABL. Just to show to you quickly that in addition to the kinase of interest, all the TKIs inhibit several other kinases also. And it is because of this off-target effect. And these are the kinases shown on this slide, which produce the toxicity of the kinase. And it is estimated that about 1/3 of the patients will have moderate to severe tyrosine kinase related side effects. And if you can stop these drugs and still have the patient in deep molecular remission, that would be the ideal way to go. Some of the toxicities have already been highlighted by Dr. Linu. Pleural effusion, pulmonary hypertension by dasatinib, peripheral and central vascular events with nilotinib and nimatinib. There has been a gradual decrease in GFR and increasing serum creatinine, which has to be monitored. and which is an issue of concern. And these drugs have been around for about 15 or 20 years. If you expose a young patient to these drugs for 30, 40, 50 years, you really do not know what kind of toxicities will happen. And of course, there are issues in giving these drugs during pregnancy and lactation. So even though TFR is a good goal and it sounds very interesting and exciting, please be aware that for patients who are started on imatinib, only about 15 to 20% will achieve successful TFR. So you still have 8 out of every 10 patients who will have to take medicine for life. And if you use a second generation TKI upfront, de novo CMLs, then you can increase this to about 30%, but still 7 out of 10 or 6 out of 10 patients will have to take the TKI for life. So really, we still have some way to go till we can say that we have cured CML. The STIM study was the first study, and I think it was a very brave study from the part of the French investigators, Francesco Mahon and his colleagues. And in the first publication in 2010, they could achieve molecular remission without TKI in about 40% of patients. We now have 5-year results of this, and we can definitely say that about 1/3 of the patients in the STIM study are off the imatinib and still in deep molecular remission. So there is science to this. It can be done. This was a very nice publication in 2016 by the group from Adelaide, Tim Hughes and David Ross, in which they first time laid down the green signals, the orange signals, and the red signals for considering TKI. And since then, there has been a whole cottage industry of studies of stop imatinib and stop TKIs from all over the world. The kids study from Korea, the Dadi study from Japan. So all over the world, patients have been reported. You can see the number of patients varying from about 40 to 110. And the extreme left column or your right column will be the chances of success, about 40 to 60%. And this is the latest update published 3 days back in the JCO on the Euroski study in which the stop TKI was practiced and reported in more than 700 patients from across Europe. So I'll just tell you a little bit more about subsequently. So ladies and gentlemen, treatment-free remission has now moved from clinical trials to clinical practice. And that is why you have ESMO guidelines for TFR, you have the NCCN guidelines, this is the latest 2024 guidelines. You have the ELN guidelines, this is 2020. It is expected to be revised this year, and it's my privilege and honor to represent you and our country on the ELN panel, which is revising these guidelines. Some little bit of difference between the ELN and the NCCN. As you could understand, the Europeans are a little more conservative than the Americans, so they would want, longer duration of TKI exposure. So now the question which I pose to you is, should stop TKI criterias be different in India and other low middle income countries, or should we follow the criterias which have been laid down and are available on publications? So to answer these questions, you need to know a little bit about CML in India and maybe the TFR studies in India. So the CML in our country is a little different because about half to 2/3 of our patients are in advanced stage in so-called 2 or 3. The majority of our patients are in the 4th decade between age 30 and 40, and this is at least 10 years younger than the Western counterpart. Quite a lot of our patients make out-of-pocket payments. We have slightly lower rates of hematological, cytogenetic, and molecular responses, possibly because of advanced stage and tumor volume at presentation, less likely to be because of different biology. Then monitoring as recommended by the guidelines for economic reasons is not as rigorous. Many patients don't get their BCR-ABL testing done. Majority of the patients get it done only once a year. Second generation TKIs is an option for the minority of patients, again because of economic reasons, but this may change with the availability of generic second generation tyrosine kinase inhibitors. Third generation tyrosine kinase inhibitors, the new STAMP inhibitor, are either not available, ponatinib is not available, asciminib is about to be available, on the cusp of being available, but it will probably be out of range economically for most patients. And stem cell transplant is an option for a very small minority of patients. And most of us believe that in the West, the patient is diagnosed at the early stage of the chronic phase, while in our country, as well as other low-middle income countries, the patient is diagnosed much later in the chronic phase when there is a lot of more genomic instability and a lot more mutations have been accumulated, and that is why that patient is more difficult to treat. So just a snapshot of a publication to show you that about 2/3 of our patients still, with all the government insurance schemes and the other private insurances, 2/3 of our patients are still out of pocket and taking a medicine for lifelong or at least for several decades is a strain on the economy. What about CML TFR studies from India? There are 4 or 5 studies which have been published in the past 1 or 2 years. The top one is the study from Dr. Pankaj Malhotra's group in PGI Chandigarh, 26 patients. The publication which you see on your left is from the Tata Hospital group, 38 patients. One TFR publication from Chennai also. And at least 2 more are in the pipeline, may have been published, but I could find these 3 only. 2 studies I have reviewed for publication in various journals. They'll be published soon. All these studies are retrospective studies, but one, the armed forces under the leadership of General Sanjeevan Sharma, who is presently posted at Leh, he's done a prospective study, and we're very eagerly waiting for the publication of that study. We had a poster at last year's ASH, which was specifically focused on TFR and LMICs. These were all GPAP patients. The BCR-ABL testing was funded by the Max Foundation, 39 patients, and about 60% successful TFR with a median follow-up of 2 years. And it can be concluded from this work, India had a significant number of patients in this, that this is possible in our country. So my take on the CML studies from our country, most are retrospective studies. We are waiting for the prospective study from the armed forces, relatively small number of patients, about 10 to 40 in each study. All use the already published inclusion criteria or the eligibility criteria. And if you look at the studies in details, all the patients in all the studies, the median exposure to the TKI was more than 10 years. And the success with an average follow-up of about 2 years in most studies, 40 to 60%. So TFR is possible in India. We have evidence to that effect now, but we urgently need prospective multi-center trials from our country. And do we need India-specific eligibility criteria? I'll put that to you, some questions to you. So these are the questions which I want you to think of, which I think still await answers from a large prospective cohort of patients from our country. What should the criteria for stopping be? And should it change with the volume of disease as presentation? Should you have the same criteria for low SOCAL as compared to high SOCAL, or should the criteria for high SOCAL be different? Then what should be the duration of TKI exposure? Imatinib should be 3 years, should be 5 years, should be 8 years, or should be more than 8 years. These are some issues, again, for which we don't have answers. I did give you a snapshot of the distillate of the retrospective studies from our country. And similarly, what should be the duration of the second generation TKIs? This again is unclear. And criteria for stopping, should it be loss of MMR, should be loss of MR 4.5 or MR 4, and the duration of deep molecular remission, 2 years, 3 years or longer. So these are the other studies which have been done in the past, and all of them have used either deep unmeasurable molecular MRD or MR 4.5. And in the Euroski study, the most significant predictor of response was duration of treatment. And this again is the recent publication from the Euroski study, 728 patients, and you can see the underlying duration of TKI treatment and duration of deep molecular response. These were the most important factors predicting successful TFR. And this was also derived from the Euroski, that the longer the duration of the TKI, the higher the chances of successful TFR. And there is an absolute increase of 3% success to TFR by 1 year of TKI exposure. And this is a linear curve. So the longer TKI you give, the more chances you will have of a successful TFR. The retreatment trigger, again, for the STIM study, it was loss of any deep response. And after that, the world realized that maybe we need to modify that. And that was shifted to loss of major molecular response. And you can see that there was no additional harm in raising the bar a little bit, but you had a lot more patients who you could successfully have the TFR. Oh, I'm sorry, I'm going back. So then what should be the frequency of monitoring of RT-PCR? That is one of the major hindrances, the cost of the RT-PCR to asking the patient to undergo a TFR, and can we do something about it? Can we modify it? We are all aware of the standard recommendation for monitoring, every monthly BCR-able testing for the first 6 months. And how do you stop TFR in a patient who's on a support program, who's on GPAP, and you're not sure that if the patient fails, then will the patient get GPAP, Gleevec again or not? And do you believe in halving the TFR dose and selecting the patients for TFR like the Destiny study? This has already been proven to work, the study from Liverpool in England. So I have a few suggestions for your consideration. The first is that TFR attempt in our country is even more important than the West because of the young population which we have. And my understanding is that the minimum duration of imatinib in our country for TFR should be 8 years. For second generation TFR should be 5 years. And why? Because we have a higher burden of diseases diagnosis. We have more incidences of non-compliance. And there is some plus minus issues with testing and greater chances of delayed testing. And the minimum duration of molecular response or deep molecular response should be a little on the conservative side. We could keep the same restart trigger as before. We could think of the Destiny strategy in patients who are high risk, reduce their TFR to half so that you reduce the side effects also. And patients who, after halving the TFR, after 12 months still remain in deep molecular response, then you put them to TFR, you'll probably have more success, but you will rule out the patients who are going to be early relapsers. Maybe we can be a little more conservative in the BCR-able monitoring after the first 6 months, because that is the time where 90% of patients will relapse. If the patient is on a GPAP program, then again you have to very carefully reevaluate these patients and counsel them. If they have access to a government-supplied TKI imatinib, then maybe you can consider them. Then you have to have a good liaison with your medical oncologist, hematologist in your medical college hospital. Imatinib, by the way, is now a part of the essential drug list, and it is available without cost at most medical colleges. You have to choose a lab which does a good RT-PCR testing, has a good quality control in the lab, And somehow you have to try and make this testing a little cheaper. And we certainly need more clinical trials to look into prognostic factors, which upfront will tell us that this is the patient who's most likely to succeed, and this is the patient who's most likely to fail. So this is a little bit of repetition of the same, and I'm also happy to tell you that I have an invitation from the EHA this year, so I'll be presenting the management of CML in countries with limited resources in Madrid in June. If you have any inputs which I could highlight to them, I'll be more than happy to include that in my presentation and convey that to the world from your side. And with that, I'd like to thank you very much for this audience.
Thank you, sir. As usual, wonderful talk, as well as this the Indian experience. Whatever we have something Western, but Indian is always your talk is more enlightened in Indian context. Yeah, definitely, and we have some challenges, especially TFR. So because most of our patients are on the Max Foundation GPAP program. So if you stop that one, they're worried about whether they'll get the medicine or not. The right please said, I think we have discussed with the Max Foundation. They said if they're still BPL, below pot line, they are able to supply the medicine, restart at any point of time. But only problem if they, about the BPL problem, there is a big financial evaluation, what you mentioned is right points. And they themselves initiated one study, sir, Max TFR study. I think we have enrolled some of the patients, they are following it. Maybe they'll get the final data of Indian patients. I think they are offering this BCR-able testing also at free of cost. So some of the issues are there, but definitely the first 6 months, I think most important, if they are willing to do the BCR-able every month for 6 months, definitely there's a very good, sir. Any other points from comments?
Thank you very much.
Thank you, sir. Thank you very much, sir, once again. So now we'll move on to the next chronic leukemia, is a chronic lymphocytic leukemia. So I'd like to invite Dr. Pavan Kumar. So he's again a medical oncologist, hemato-oncologist, and bone marrow physician. So in the Basavadarakam Indo-American Cancer Hospital. So Dr. Pavan, I think.
Thank you, sir. Thank you for the introduction. First of all, I want to thank ICON team for inviting me on this platform. And I want to apologize upfront. Probably I'll try to stick to the time and probably I'll have to rush through. So the topic for today is managing CLL in 2024. I will start with most of the, I'll not go through the diagnosis and other parts. I'll stick to the treatment part. So in 2024, 2023, 2024, the major part before starting the treatment is the cytogenetics in CLL. And now the most important, I think we have, everybody does the FISH and CLL panel commonly, and the most important cytogenetics we are looking for is 17p del. So 17p deletion even before prior to chemotherapy had the worst prognosis, and subsequently there is another entity in 17p del where is something called T53 mutation, which can be different from 17p del, and a combination of 17p del and TP53 mutation, they actually fare worse than the people who have a single alteration, probably 17p or TP53 mutation. And most of us, we don't do a separate NGS for TP53 mutation, so we tend to miss that part. And apart from the cytogenetics, IGHV mutation, I think evolving treatments in 2024, we probably have the same treatment for all the groups. Take 17p del or IGF mutation. So we'll start with the background of cytogenetics and the prognostic factors. Now, in present era, the CLL treatment is based on whoever is getting treated, in the sense that major indication of CLL, treatment for CLL has come over. So we get a 17p del patient, whoever has 17p del, we have two ways of treating. One is continuous treatment with one of the BTK inhibitors, can be a zanubrutinib or Acala, and we have good old ibrutinib. Acala we can add an obinutuzumab, and patients who have a fixed duration. So obinutuzumab, venetoclax, which unfortunately venetoclax still not available in India, so it's other way, we are getting in other routes, but still we don't have an option of fixed duration concept in treating in India. So options of venetoclax, obinutuzumab or venetoclax, ibrutinib. So same part applies to patients who have 17p del negative. If you take care of IGVH mutation, patients who are unmutated and muted, they almost have the same way of treating. Nothing has changed. So End of the day, all treatments with the new NCCN guidelines also, all treatments, there are only two things right now in CLL. One is fixed duration or continuous treatment. Continuous treatment is with the BTK inhibitors, with or without addition of a CD20 antibody second generation, or fixed duration which has a BCL2 inhibitor, that is venetoclax and obinutuzumab, or ibrutinib and venetoclax. So the new targeted therapies, we have evolved from chemotherapy, from 15 years of experience from my residency days to till here. So good old treatment then was FCR. We were scared to give FCR, so Arbenda came in and took over the whole way of treating CLL. But now I think we are moving away from chemotherapy with the availability of new targeted agents, that is BTK inhibitors, BCL2 inhibitors, and second generation CD20 antibodies. Now, coming part, how we treat, the two ways of treating, like we discussed, is continuous therapy. So continuous therapy actually involves BTK inhibitors, especially now in the present generation, zanubrutinib and acalabrutinib. Acalabrutinib can be given with obinutuzumab also. And we have only acalabrutinib in India and probably and obinutuzumab. Starting with acalabrutinib, so the Elevate-TN study, they had actually looked combining acala, single agent or acala with obinutuzumab, and they compared it with the chlorambucil obinutuzumab. I think by now we have gone through all those things. So acalabrutinib with or without obinutuzumab tend to really fare well in the PFS compared to the chlorambucil arm. And it also happens in the 17p deletion or TP53 or an unmutated status. So we have very clear winner here, acalabrutinib, with or without obinutuzumab. Definitely obinutuzumab slightly has a better edge when you give combined with acalabrutinib. So the major point I want to stress through in this trial was the MRD negativity. The whole CLL has, after CLL14 trial, the MRD has come into CLL also, and that's one of the most important prognostic factor after 17p del. And there are only two drugs after chemotherapy in the new era which can induce MRD negativity, that is obinutuzumab and venetoclax. Only these two drugs can actually induce MRD negativity in CLL. So here, when the obinutuzumab was added to acalabrutinib, you can see there's 42% patients actually achieved a MRD negativity. Same, if you take single agent acalabrutinib, only 10% patients. So obinutuzumab actually added the MRD negativity here. And coming to the other drug, zanubrutinib, so it's not available in India just for sake. And they have compared the zanubrutinib in 17p del negative patients with the bendamustine rituximab, and PFS is definitely better than the chemotherapy. And they have even compared and as a single arm study in 17p del patients, and almost 2 years, 18 months PFS is almost 90%. Now, so we after going through the continuous treatment where the patients have to go through continuously, the biggest issue with the BTK inhibitors, again, you have the cardiac complications and the fatigue issues. Now we have something called fixed duration, where we can stop treatment somewhere. So 1 year, 1.5 year, 2 years, 3 years, as per a different protocol. Now the options available are obinutuzumab and venetoclax, obinutuzumab, venetoclax with ibrutinib, or ibrutinib, venetoclax alone, or zanubrutinib, venetoclax, though the data is not still mature enough. Touching through everything, so CLL14 is the major trial which actually made us to understand that MRD is also important in CLL. So this is comparison of venetoclax obinutuzumab with chlorambucil obinutuzumab. There were a lot of patients with 17p deletion, almost 12% patients. And there's clear data which says venetoclax of obinutuzumab has a better PFS, almost tripled compared to chlorambucil. And obviously the control arm is way weaker to expect anything. And the same PFS benefit stands in patients with high-risk TP53 mutation and even in IGHV unmutated arm. So both patients definitely had a better PFS. Now comparing them, it's the same CLL14 trial, that is venetoclax, it's a cross trial comparison compared with the Resonate ibrutinib arm. The PFS is almost 70%. But the major point I want to show you here is the patients in venetoclax and obinutuzumab arm had a high comorbidity index. More than 86% patients had a more than CRS score was more than 6. So 90% patients had a high comorbidity index compared to only 31%. I think it's very clear. Ibrutinib, we know they have a cardiac toxicities, and most of the patients of CL are elderly and tend to have cardiac comorbidities. So, and next, and comparing with acalabrutinib per se also, it actually fared as same as that 63 and 84, but here also the most of the patients in the BTK inhibitor group, that is Elevate NTN trial, 14% patients were only having a CRS score of more than 14%. Here it's still 86%. Most of the comorbidity index patients were in the venetoclax obinutuzumab arm. The response rate expected will be definitely high in venetoclax obinutuzumab arm. And the major part here was the MRD status. So you can see the two major drugs which can actually induce MRD negativity are obinutuzumab and venetoclax. So 76% patients in the peripheral blood and 57% patients in the bone marrow had MRD negativity. So which is a big number. And this trial actually showed that MRD negative patients tend to have a better PFS compared to patients who are MRD positive, and better OS compared to MRD positive patients. So the MRD was around all the subgroups. So 53% of the patients in CLL 14 arm, 14 trial were in CR or without any, were CR and MRD negative even after stopping cessation of the treatment 5 years back. So CLL 13 is just an add-on. They have compared multiple drugs together, good old chemotherapy with obinutuzumab and venetoclax, and also obinutuzumab venetoclax with ibrutinib. It's a multi-arm study. Just to point out, and also rituximab and venetoclax. So what the point I want to make here is, the rituximab with venetoclax is equal to chemotherapy and inferior to any of the obinutuzumab and venetoclax. So rituximab per se doesn't have any extra advantage for venetoclax, but obinutuzumab definitely will make a difference. Almost 85 to 90% patients had MRD negativity when with the obinutuzumab venetoclax plus or minus ibrutinib arm. So primary PFS, definitely PFS will be high in patients with obinutuzumab and venetoclax without ibrutinib. So same holds to the unmutated, and no P53 patients were used here, so there's only unmutated CLL group. Now come to the two oral drugs. Now no more injectable, oral drugs. The oral drugs, what we have, ibrutinib and venetoclax. So I want just bust to two trials, Captivate, where they have used in younger patients, two drugs combination, and there's no comparison arm, so almost 90% PFS at 2 years, and MRD negativity at almost 70-75% patients are MRD negativity. And there's another trial called GLOW. They checked this trial in an elderly population, more than 75, same thing. They compared with the chemotherapy arm, and there's nothing to guess here. Ibrutinib venetoclax fared better. MRD negativity, it was almost 50% of the patients had MRD negativity, and all along the subgroups. FLAIR trial, this is the only trial which actually compared this ibrutinib and venetoclax with FCR. Nobody compared all this control. This is the only strongest control arm we have here. And as we expected, ibrutinib venetoclax will definitely sail better. And MRD, you can see the MRD status there. The MRD is always, the blue line is MRD negative, and it's been around continuously plateaued with ibrutinib and venetoclax. So brushing through, probably I'm running out of time. And same recommendation. Only one thing I wanted to add for the relapse setting, nothing new in 2024, except a new drug, there's only one trial which compared two BTK inhibitors, zanubrutinib and ibrutinib. So zanubrutinib is definitely better than ibrutinib in relapse refractory setup because of better tolerability and better efficacy. So thank you. Probably I cross 3 minutes more.
But I think you have covered almost. Thank you, Dr. Pavan. I think you have covered almost all the topics. I think CLL, again, it's a very mild disease. Once upon a time, we used to say it's a age-related problem. I think most of them, they may not need any treatment also. So where we have come from that chlorambucil, visolone to now we have the BTK inhibitors and monoclonal antibodies. But thing is, I think where even though we have many drugs, but better to choose the drug, choose wisely, so whether the patient needs these high-end therapies or not, and based on that we can, genetic profile nowadays, MRD, everything we are incorporating into the management. So thank you, Dr. Pavan. I think, but of course, they rushed your time, but ultimately you have done a good job. Now I would like to invite, I think the speaker name changed to Dr. Madhav Danthala. He's again a hemato-oncologist and transplant physician. So he's from Yashoda Hospital, Somajigoda. And he is going to talk on who is the right candidate for autotransplant consolidation in CR1, not 11, first, okay, induction. Dr. Madhav.
A very good afternoon. I'd like to first start off by thanking the organizing team of the 50th ICON for giving me this opportunity, and it's nice to see a full hall at this time. So without further ado, I'll get straight into the topic. So we're going to try to answer the question of who is the right candidate for an autologous stem cell transplant consolidation in CR1 in NHL. And I'll be discussing the role of the transplant in DLBCLs, mantle, follicular lymphomas, TNHLs, and PCNLs. We'll start with large B-cell lymphoma that includes PMBCLs, high-grade lymphoma NOS, and double and triplet lymphomas. So the SWOG 9704 trial looked at autologous transplant as a consolidation for aggressive NHLs. So patients categorized as the high intermediate and high risk according to IPI were randomized to receive autologous stem cell transplant as a consolidation, and it did improve PFS, but OS was not improved, probably because of the effectiveness of salvage transplant. And we've gotten better at categorizing patients of high risk lymphoma, DLBCLs. And one of the categories that a lot of trials are being done is if transplant does have a role in CR1 and double-hit lymphomas. However, most of the data that's available thus far is all retrospective in nature. For instance, this paper by Petrich et al., where they looked at patients who had achieved a CR to frontline therapy, and the median OS was similar to those who were observed, and PFS data was not available in 69 patients, and the PFS data that they had presented was questionable. Data coming out of MD Anderson, again, not much difference in outcomes between frontline stem cell transplant versus no transplant was not significant, and there were very small numbers with a shorter follow-up. This was the largest prospective data that has been presented by Landsberg et al. Again, 3-year RFS and OS rates did not differ significantly for stem cell transplant. And the 3-year RFS and OS did not differ significantly for patients in the R-CHOP or intensive therapy cohorts when analyzed by receipt of stem cell transplant. Again, a paper where they looked at consolidating with an autologous stem cell transplant after dose-adjusted epoch-R. A 24-week landmark analysis after diagnosis, the 2-year PFS and OFS were 94%, but there was no apparent benefit from consolidating with a transplant in responders, and most responders have a durable response, thus highlighting the efficacy of dose-adjusted epoch-R as induction in double-hit lymphomas. So this is the latest algorithm from ESMO, again, how I treat DLBCLs. Double or triplet lymphomas consider R dose-adjusted epoch-R in high-risk IPI patients. And those with higher risk advanced disease, again, we now have POLA-RCHP as an option. So the jury is still out on this one. Moving on to primary CNS lymphomas, the debate between an autologous stem cell transplant and whole brain radiation RT has been settled in favor of stem cell transplant. So this consolidation conundrum is more or less, I would say, settled. PRISIS favored stem cell transplant, by the IESLG 32 found both equal, but the neurotoxicity data observed in the PRESIS 8-year update favored stem cell transplant. Moving on to the IELSG 43 trial. So this, again, the debate between non-myeloablative chemotherapy and compared to high-dose chemotherapy followed by autologous stem cell transplant as consolidation in primary CNS lymphomas. This trial has shown that there's a clear role for high-dose therapy and autologous transplant, and this was a randomized controlled trial. The overall survival there was significant. 86% in those who underwent transplant versus 70% in those that did not, and there was a 54% reduction in death, albeit at the cost of a slightly more toxicity. But I would say, based on this trial, I mean, autologous stem cell transplant is the way to go as consolidation in primary CNS lymphomas. Moving on to mantle cell lymphomas, what we've been doing all along now for young and fit patients is giving them R-CHOP or RDAP or any other protocol that includes cytarabine based on PFS benefit for 4 cycles, followed by a consolidation with an autologous stem cell transplant, followed by maintenance Ritux for 3 years based on an EFS advantage. So role of transplant in the pre-Ritux era trial conducted by the European MCL network, patients who received interferon maintenance versus those that received a transplant, there were no differences in the OS, but stem cell transplant again significantly improved PFS in comparison to interferon maintenance. This was in the pre-Ritux era. Now this is the latest trial. The abstract was published at ASH, the triangle trial by the same group, European MCL network, and again outcomes again. Although longer follow-up is needed, what the results of the 3-arm randomized triangle study did show us that ibrutinib may replace autologous stem cell transplant after chemoimmunotherapy in younger patients with previously untreated mantle cell lymphoma. The study also found that when ibrutinib was added to stem cell transplant, the 3-year failure-free survival was significantly superior to stem cell transplant alone. Furthermore, the 3-year mark with no difference in FFS was observed when ibrutinib was added to stem cell transplant or given instead of stem cell transplant. And this study appears to usher a new standard of care for some patients with MCL, but there are a few observations. I mean, the median follow-up was 31 months, so we do have to wait for the full paper. As you know, in mantle cell lymphomas, for safe addition of cytarabine, there's a PFS benefit, but even the 10-year update did not show any OS benefit. So if you're talking in terms of outcomes for mantle cell lymphoma, 3 years is still not a long duration. And also there are several other questions. Again, what's the efficacy of these drugs in the second line when you're retreating? And also the question of whether results would be similar if you're considering other high-dose cytarabine combination Ritux inductions, and whether the benefit seen with p53 expression by HC will actually translate to those with TP53 mutations alone. What this trial does tell us is that ibrutinib can be delivered safely in younger patients versus a different outcome that we saw in the SHINE trial where excess toxicity was seen in older patients. This trial obviously does not answer the question of whether stem cell transplant is the way to go in consolidation. So till the time that the final results are out, we would still continue to give stem cell transplant as a consolidation in the first line. Moving on to follicular lymphoma. Follicular lymphoma, again, given the inevitability of tumor progression in follicular lymphoma patients, stem cell transplant was investigated as a consolidation method in CR1. There were 3 RCTs in the pre-Ritux era in CR1 by the GLSG group, the Gela and Golem's group, and the consistent results showed a PFS benefit but no OS advantage due to transplant toxicities such as acute effects. And what was striking was in most of these follicular lymphoma transplant trials, there was a much higher incidence of secondary malignancies, but when you look at the data, most of these studies included TBI as conditioning. The one trial that included BEAM as conditioning, although its retrospective data did indicate that the secondary malignancies were seen only in patients who were transplanted in later than second remission. Because the follicular lymphoma patients, they have multiple remissions, they go on to receive several salvage therapies before finally going on to receive a transplant. So that could be a possible reason. Again, follicular lymphoma trials in the Ritux, follicular lymphoma, again, transplant in the Ritux era. There's a Gitmo trial that, again, looked at comparing a conventional R-CHOP versus intensive high-dose therapy followed by transplant. The high-dose therapy followed by transplant did ensure superior disease control and molecular outcome, but there was no OS improvement. So the setting that, again, R-CHOP failures have a good outcome after salvage, suggesting that relapse refractory FLs could be most appropriate setting for transplants. And in this trial, again, the cumulative incidence for secondary MDS and AML at 4 years was 6.6% in the high-dose arm. So summarizing, in follicular lymphomas, especially in the era of therapeutic antibody maintenance, evidence of benefit of stem cell transplant in CR1 is lacking in patients with untransformed follicular lymphoma, and in those high-grade transformations who have not received any systemic treatment for the underlying FL before histologic transformation. In contrast, consolidation with an auto-HCGT may be a clinical option in patients with chemosensitive high-grade transformations if they had received prior systemic treatment, especially immunochemotherapy. And the optimal scenario is a CR2 in early progressive disease, and always make sure you rule out a transformation in such patients. Moving on to peripheral T-cell lymphomas and consolidation in the autologous stem cell transplant in CR1, unfortunately, there's no randomized control trial data that has compared the transplant versus no transplant approach, and the majority of available literature is registry and retrospective data, and there are only a few prospective data sources. In the retrospective data, again, only patients who underwent a stem cell transplant were included. So there's a lack of uniform consensus regarding the role of a stem cell transplant in CR1 and PTCLs, and comparisons between studies have been challenging because of inclusion of diverse subtypes and also because of variable response to induction chemotherapy at the time of transplant. Two types of TNHL, specifically ALK-positive ALCLs and strictly localized nasal ENKTLs, typically have a favorable prognosis. For all other types, a transplant might be required is the question. And another important point to note is that most of the registry data have reported transplant rates as high as 50 to 60%. Whereas if you look in the real world, it shows only a rate of roughly around 20 to 30%. So the potential benefit of consolidation with autologous transplants is built on single-arm data, most notably the prospective NLT, the Nordic Lymphoma Group NLG TO1 trial, which is the largest prospective study that included 115 patients. And patients received CHOEP or CHOP, followed by high-dose chemotherapy and transplant. And the transplant rate in this trial was 70%, and with a median follow-up of 5 years, the 5-year PFS and OS were 44% and 51% respectively, and this appeared to be better than historical expectations. Again, several other studies, like I had mentioned, that looked at consolidating autologous stem cell transplant in the first line. There were trials that had negative results, like the retrospective LYSA study, where the analysis by intent to transplant and a multivariate and propensity score matching showed no benefit of stem cell transplant. Compare that with the Norwegian registry, which did show that patients did benefit from an autologous stem cell transplant in CR1. Also, the recent trial, Echelon 2, if you look at the subgroup, analysis of patients in CR, the benefit of stem cell transplant was seen in patients who were on the CHP Brentux's arm. With 5-year PFS of 63% and a 5-year compared to 49% in those that did not. So where are we at in terms of transplant for peripheral T-cell lymphoma? So although high quality evidence is lacking supporting transplant over no consolidation in CR1, there are large reports both supporting and not supporting stem cell transplant. There seems to be a growing preference for the former over the latter, especially in AITLs and PTCL NOS or ALK-negative ALCLs. Again, I have not discussed it, but there is a randomized trial data where allo is better than auto in certain subsets of peripheral T-cell lymphomas like ATLLs and CTCLs. At present, an in-depth decision with the patient is warranted, aiming to let the patient know that this is a toxic procedure, could very well not offer any benefit, but that relapsed PTCLs have a poor prognosis, and that obtaining a CR2 is not always possible. The randomized control trial that is looking at looking to answer this particular question is the transcript trial, and we are awaiting the results of that to give us further direction. So to conclude, these are the indications for stem cell transplant according to the European guidelines published in BMT in 2022. Again, LBCLs, intermediate and high IPI diagnosis, the level of recommendation is it's a clinical option. For follicular lymphomas in CR1 untransformed, it's generally not recommended. For FLs, CR1, for those transformed into a high-grade lymphoma, again, it's a clinical option. For mantle cell lymphomas in CR1, still the standard of care, and for PTCLs, it's a clinical option. Thank you for your time and attention.
Thank you, Dr. Madhav. You have completed the task before 2 minutes. So any other comments from any of? No?
Thank you.
Yes.
Allotransplant for PTCL was considered as a negative thing in terms, so one should not be considering allotransplants in PTCL because it had an inferior outcome. That was what was presented at last ASH meeting.
Point is taken. Yeah. I think this was based on the German RCT, whether it showed the allo over the auto.
Okay.
Thank you.
Thank you, Dr. Madhav. And now we'll go on to the next this panel discussion now. So, improving outcomes of DLBCL in India, current treatment strategies and future options by Dr. Menon sir. I think he doesn't need again introduction, but he's the senior professor and everybody knows him as a famous hemato-oncologist, especially in India. So, he's from Bangalore now. Again, I'd like to invite the panel members now. Santhosh Kumar Devadas, medical oncologist from Visakhapatnam. Ashok Kumar, Hyderabad. Ramavat Dev from Visakhapatnam. Ranjit Kumar from Hyderabad. Kinjal Shah from Hyderabad. And Smita Saldhanha from Bangalore. And Dr. B. Shravan from Vijayawada. So, over to you, sir.
Okay. Santhosh is there, I didn't know that. Yeah, okay. Okay, while my panel is welcome, I welcome the panelists and thank you for the opportunity. It's a pleasure to be here. And as Dr. Malhotra, even though I've not been there for 40, I must have been there for probably 10 or so of these ICON conferences. So thank you once again, always a pleasure. So it's always good to kickstart the conversation, what we know about DLBL what are the data that is currently available? We know that it's more so with an elderly population. A good majority, about 50% of them come in late stage disease. Another 40% of them have about a higher IPI score, and again about 50% or so of them present with extranodal disease. Bone marrow involvement about 20%, and CNS disease is, even though it's a definitive thing, it's not as common as we see, approximately up to around 3% in various series. So we are able to cure about 50 to 60% of the patient, and that has stood the test of time even after the advent of rituximab 20 years ago or more. And about 20 to 30% of them relapse, and 5% are in partial response after therapy. And we know that overall about 25% of them become eventually refractory to treatment. And so in these first 50-60% of the patients, there's unlikely that you can improve upon them. And whatever you do, that's going to be and they're going to be cured of the disease. And it's the next set of patients that we need to really identify. And these are beforehand to improve outcomes and improve upon the outcomes in these. Why so is also, this is an elegant study from the Swedish registry, which looked at what happens to the patients who relapse after diffuse large B-cell lymphoma. And if you look at the left-hand side, as we said, about approximately 50% of them are cured of the disease. And when we try to wake them up or try to get them relapse, almost about still you will see a proportion in the gray area, which is they do not respond, and they eventually transition to death over here. And there is only again a small proportion whom we can get on to some sort of a remission so that they live to fight another day. And as we go to the second graph and the third graph, the responses that we achieve is almost dismal, and it's in the form of a few months, and it is even worse than even solid tumors, and most of them eventually die of the disease. And the ability to salvage them with whatever we have in terms of transplant, etc., we know we'll discuss that, is quite dismal in terms of outcomes. So we have the best chance the first time around, and not so much in the second time around, though we have now new modalities of treatment, which we will discuss in the panel discussion. And it's always good to see some of our Indian data, and I'm happy to be part of this largest study, which we looked from the OncoCollect registry. And it was heartening to see that our data and our outcomes are also similar to the West. There's, contrary to what people say that our outcomes may not be there, it's about the same, close to around 60 to 70% of the patients were doing well at the end of, even though the follow-up over here, the median follow-up was 3 years, but still, we know that about if we cross the 24-hour-month time point, the response is sustained, and that is what we see over here, irrespective of the IPI score, the 3-year event-free survival based on use of rituximab versus no use of rituximab, and everything is in par with what we see as terms of outcomes from the West. So, so now we get back to the panel discussion. So, I just get back into the depth of things itself straight away. I'll start with Santhosh. And can we prognosticate DLBL better than what we do these days over here? Yeah.
So, in practice, we want to do whatever is possible. What we do in our center is make sure that we do the FISH test irrespective of whether it is a ABC or a GCB. And the present prognostic measures are not, the IPI, RIPI and the CNS IPI, I think, are not equipped well enough to prognosticate patients very accurately.
Dr. Smita.
I think one of the parameter was the FISH, as you mentioned, the double hit, double expressor. As we know, these are supposed to do more, have a better, worse prognosis. And the earlier Hans algorithm or the method of classifying them as GCB, non-GCB, where we knew GCB probably did better compared to non-GCB. But still, we don't have very categorical guidelines or for prognostication. And the IPI score, I think, is actually not a good method to prognosticate the
But it still
DLBCL.
holds good, isn't it?
It holds good.
Yeah.
We do treat
the
the patients
bedside,
according to the IPI score and the age-adjusted IPI or the CNS IPI.
Yeah. Can we use those in a doctor?
Yeah, definitely these are the clinical parameters. They do have some correlation with the outcomes. But I would say molecular profiling of DLBCL would give us better picture than just the clinical parameters.
Though we have understood so much about the molecular profile, has it really impacted our way that we treat our patients? And I mean, your opinion, Doc, and I mean, sorry.
So I feel, sir, we have not well understood the molecular profiling specifically in this lymphoma panel. There are multiple studies which quote there are multiple epigenetic mutations which are coming up in now lymphomas and all, which are not well known. So I feel a deeper NGS analysis and
So we have understood significantly much of the molecular landscape. Have we been able to, has it become relevant? Is my question. I mean, in your opinion, has it become relevant enough for us to be utilizing it for real time to improve our management of diffuse large B-cell lymphoma?
As of now, we are not able to implement it as a prognostic or a predictive value to those molecular testing. But I feel if some epigenetic mutations and all those things can play a more role in this part of the...
So in terms of your understanding, what has been the, I mean, in terms of the prognostication, how has it fallen short for us? Your opinion on how has it fallen short for
So because at most of the centers, we are still not doing all the NGS and all those tests.
No, what if we were able to do it also? Do you think that has made a difference is the question?
I feel there can be some other driver mutations or something which will predict the, or we can find something which we can target, or something that can tell us like this therapy won't work good for this pet. So more of personalized medicine in lymphoma rather than giving the R-CHOP to all of the lymphomas is what I mean.
Doctor, your opinion?
As of now, all the strategies which try to improve the backbone or the backbone R-CHOP had showed no possible benefit. With the available...
That has been very disappointing, isn't it?
Yes.
Yeah.
So the only promising was POLA RCHP, just shown. Otherwise...
But the data is also not fully
not
mature,
yet matured.
Santhosh, your...
So is the first question?
Yeah, no, the next question, cell of origin classification. I just go through that. I mean, we do have, and it has been there in existence for more than 2 decades in terms of understanding that the GCP and activated GCP, they behave differently, their pathways are different, and probably there may be a potential to target them in these. So have you been able to target any of the cell of origin population for benefit in terms of, and in any area where we have been able to target that, in terms of the pathways that are different for in diffuse large B-cell lymphoma?
In clinic, the three things we try to do to improve outcomes based on overall the presentation, etc. One is if we feel the disease very aggressive, is going to relapse, based on the remark data, use of lenalidomide maintenance is one. Based on the Polarix trial, where our CHP was combined with polatuzumab, the ABC subtype was found to benefit more in the unplanned subset analysis, and also proved later in a meta-analysis that the ABC subtype high risk may benefit more with addition of pola. So the high risk ABC, we do offer polatuzumab upfront, and in a double hit patient or triple hit patient, though as Dr. Madhav was presenting, though it's not standard of care, we do offer in a young patient, post R-CHOP, we do offer a autotransplant because if they relapse, that's it.
So, yeah, Dr. Smitha, your comments on that? I mean, what is in your practice?
So usually we do not differentiate the treatment based on the cell of origin as of now. Most of the places we're giving R-CHOP itself. But I think there were, as mentioned, lenalidomide is one option which we give as maintenance. And the other thing is with the
So if you were to pick and choose, who are the people you want to use for maintenance lenalidomide? Who would they be? Would it be across the board?
The data also shows the benefit is more in the ABC group, the non-GCB type. Okay. So probably this subgroup.
And probably the data would had suggested that probably in the elderly population there may be some benefit from prography. Your comments on that?
So for me, the classification of GCB and ABC is more of a prognostic rather than therapeutic. I mean, yes, there is some data suggesting that 60 to 80 years lenalidomide has shown some PFS benefit, but that has not translated into overall survival benefit. For that 60 to 80, for that
and
PFS
always one
benefit,
forgets about the toxicities associated.
Yeah, that's what I don't want to give additional toxicities to this population. So as of now, I won't intensify my treatment based upon GCB or ABC.
Yeah.
So same for us, we do not differentiate, but yeah, we definitely suggest polatuzumab addition for the patient who are having ABC subtypes.
So you have a comment on that? Yeah. So definitely we have been able to identify different subsets. ABC behaves worse off than the GCB subtype, and also the addition of rituximab overcomes some of the problems of associated even with the ABC, and they pull up the ABC survival and progression-free survival as against not using rituximab. So rituximab has an impact in both. But having said that, the GCB subtypes behave better than, and also the ability for us to manipulate anything in the pathways that are associated with the GCB subtype has not been very encouraging. Maybe there were some signals in terms of the ABC subtype, and that is what was looked at. And there are some other pathways also that have been looked at. The Notch1 signaling pathway is the EZH2 overexpression, which is actually one of the few markers which have actually resulted in some sort of a positive outcomes in these patients as against all the negative outcomes for all Notch1 signaling, and also the P53 mutation, as we all know. So again, as Santhosh said, and all of my panel have agreed to, there were two papers at the same time which was contradictory. One which was showing that addition of lenalidomide actually benefited in terms of, this was the first paper, and around the same time, the same idea came, it did not really show much of a benefit. And but of course in the remark study, which looked at the introduction of maintenance lenalidomide in patients of the ABC subtype, there was some improvement in progression survival, but that was again confined to some of the older population, perhaps because the older population may have received a little bit of lesser chemotherapy as against the older population, I mean the younger population. And we know it was negative, the use of targeting the NFK-kappa B pathway in ABC using ibrutinib. Probably there was a signal for some sort of, in terms of tolerance, better in a younger age group, but it was a strict no-no for elderly patients for using ibrutinib, and it was a negative study. And so was the bortezomib, which fell flat, trying to exploit the NFK-kappa B pathway. So so have you ever thought of looking from the agnostic approach of the cell? Because we have always been entrenched into these, into the COO pathway, and whether we're looking at an agnostic approach. So irrespective, and suppose you have a patient who is in a low IPI, an early stage disease, do you in practice go in, as was shown by the FLIRE study, about abbreviating chemotherapy? I can start with the other end then. Yes.
No, sir. The only change is if the patient is elderly, I would try to cut down the chemo. Otherwise, stick to R-CHOP.
For early stage without any then low IPI and early stage, you still would go ahead with, you don't abbreviate the number of cycles, you still go ahead with 6 cycles.
6 cycles, but mini CHOP, elderly.
Okay, for elderly.
So for limited stage patients with the low IPI, so basically we do risk adapted therapy for those limited stage patients also. So we usually do 3 cycles of R-CHOP. After that we do a PET. If they are PET negative, 1 more R-CHOP, and that's it. So we do it only 4 R-CHOP for poor, for limited stage and a good response.
The thing of, even if you're not giving radiation, you would just
yes,
give,
definitely
you give 2 additions of a single agent rituximab as per this FLIRE study.
Yes.
Okay, thank you. And in your practice, and I'll just ask.
So usually early stage, non-bulky and low IPI, good performance status, maybe 3 to 4 cycles of R-CHOP.
So do you follow the Canadian route, or do you follow the FLIRE route? That's the one question as well.
Canadian group.
Yeah, that's good. Yeah, Dr. Smitha?
I agree with what they have said, sir.
Yeah.
Mostly we do the same thing. Limited
So
disease.
if you're giving limited stage, you follow it up with radiation, or
if it's bulky disease, we give radiation, more than 7.
You
bulky.
do. If it's bulky, you give radiation, and yeah.
We do exactly what the FLIRE did.
Yeah, just give 4 cycles,
yes.
and the thing, because the data was very clear. But you have to pick and choose your patients in FLIRE study, because it was a very strict inclusion criteria. That's something that has to be kept. They were early stage, truly early stage, non-bulky disease, and not more than stage 2A. Yeah. So, so this is just to go through, and we thought then, in your practice, where are the situations where we are going to use for incorporating anti-drug conjugate with the polatuzumab study which has come in? Santhosh.
Sir, I mean, if you look at what other people are doing, they're practically offering it for everybody, but obviously it's horrendously expensive.
That's why I asked you, it's very difficult to
horrendously expensive. So I would definitely pick and choose like a very high risk subset, elderly patient who will never get a transplant.
How is it you have decided on those very high subset only to use polatuzumab? Was it based on data, or was
based on data? ABC, which the meta-analysis done showed ABC will benefit, and the ones who will never get a CAR-T or a transplant if they relapse would be the ones whom I would pick and choose.
Yeah, go ahead. Anyone can take it.
I would select Pola in specific subsets, especially those patients who have ABC subset, bulky disease, then high IPI. These are the subsets I usually tend to. Apart from that, even those patients who have double hit or triple hit, if they can afford, I would select Pola in these subsets as well. If you're not planning to give dose-adjusted EPOC.
Yeah. So why would you choose a dose-adjusted EPOC? You would still use a dose-adjusted EPOC over here.
Yeah, that we can use in those patients who have a double hit.
But would you still want to use it with the overwhelming data that has come up that it doesn't have an added advantage over R-CHOP?
So most of these data which we got with the dose-adjusted EPOC are retrospective. We have a good meta-analysis.
No, the CalGB study was a prospective study which was randomized.
In most of these studies, they have shown to have a PFS benefit. I didn't see of any overall survival benefit in all these subsets. This is the only trial which has shown to have little overall survival benefit. That's why I would be more inclined to use Pola than the dose-adjusted EPOC in rest of the, indications.
Yeah.
In ABC subset and higher stages and higher IPIs, if possible, POLA. Whether it's double hit.
So that's probably triggered by the fact that the study actually had a good measure of patients who were in the higher IPI, higher IPI, and they benefited in that. Smita, is that right? I mean, yeah, you would.
And also ABC subset had a better benefit.
Yeah, okay. So this is what has been shown. I mean, there's a real good feel about the use of polatuzumab in the frontline setting, because if you look at this forest plot, you have majority of them skewing more towards the benefit, but the cost is incredible. And the one problem that we have over here is that we don't have the data which is still mature. It's the maximum is a 3-year survival data, which is still not shown a benefit in terms of an overall survival, but trend, as you'd like to use the trend towards overall, but certainly a benefit in progress-free survival. And as everybody was talking about, there is a benefit seems to be emerging more profoundly in the ABC subtype. So, and again, it may be something that we want to look in the elderly patients where we do not use so much of anthracycline-based regimen. Sometimes we have difficulty, so maybe to add that to the regimen. So in conclusion, for adult, we don't have too many things happening. We know that intensive therapies have not really worked. It's important to understand the profiling. We do the FISH analysis over here. Using more intensive chemotherapy may not be so beneficial, but adding something to the backbone of the R-CHOP backbone may also not be too beneficial. And but some for tractable targets for ABC, there might be some benefit in using in select patients, maybe like what the REMARK study has shown. And also, we need to have more long-term data on overall survival with conviction to say, and I hope it goes the same way as the brentuximab vedotin story for Hodgkin's lymphoma, where there was a sustenance of the progression-free survival translating into some overall survival benefit. So we come back to the last part. I have another 9 minutes. Let's see how we can go through the relapsed refractory diffuse large B-cell. So again, I'll start with from the middle, for example. So is there a role for revisiting biopsy? Do you do biopsies of patients who have a relapsed disease? And this is a very critical situation over here, because as I said in my third graph, I mean, relapsed disease is a tough disease to handle, whatever it is.
Yes, I think I do re-biopsy in all of my patients who present with relapse. First, if they present within within 6 months, just to confirm it is DLBCL itself, and the other parameters, I want to rule out other conditions as well, like granulomatous diseases sometimes can have uptake, and I just want to differentiate that with relapse. And also there could be molecular change, the change in clones, which because of improved molecular profiling these days, I know this will not determine my treatment, but it's always better to know what kind of disease I'm dealing with.
So knowing that, would it influence your treatment, Smita, in terms of what you need to plan for the patient subsequently?
The treatment depends on the time frame, the disease-free interval, if it's less than 12 months or more than 12 months.
No, in this case, about the biopsy, of knowing something more on the biopsy. This one.
Biopsy per se, just if there's any transformation or anything from other low grade to high grade, but in a DLBCL per se, usually may not be of much
Suppose
use.
we didn't have in the previous thing, whether it was an ABC type or a GCP type.
That definitely requires.
You would like to do
we need to know if it's GCP
would it
or
influence
ABC.
the way that you want to treat the patient subsequently? Besides, of course, you said the time frame. Would you be more discerning about that in terms of what you want to use over here, in terms of the kind of salvage that you want to use, for example?
So if it is less than 1 year, less than 12 months, we'll think it's chemo refractory. So probably there the role of CAR T cell will come in more. If it's more than 12 months, the role for salvage chemotherapy followed by transplant.
Yeah. Yes, Santhosh.
Sir, the RDHAP versus ICE, there was a benefit with in the GCB subtype. That's the only way.
The biochoral study which you showed. Yes,
other than that, I don't think it really changed.
Yeah. Any comments from your side? Yeah. So So that was what Santhosh was talking about, the biocoral study. Whether you use RIs or whether you used RDAP, it didn't matter when it came to ABC subtype, for example. But in the GCB subtype, there was probably a little bit benefit for using DHAP as against using the RIs regimen. So maybe if you want to be more discerning, and especially in those patients whom you're looking up for going in for a transplant, who had beyond 1 year of relapse, in those patients you may want to be a little bit discerning about the choice of salvage use. Otherwise, there's really nothing to go by in terms of the type of salvage that we use. And more importantly, and the use of autologous stem cells. So what proportion of patients of yours in the salvage setting do you offer transplant, or are you again careful about adopting autologous stem cell transplant in a patient who has relapsed in DLBCL?
So we know this from previous data that only 50% of our patients who relapse get some sort of a remission at the end of when we try to get them into remission. So eventually only 50% do get a transplant because just the fact that the rest won't respond.
Yes.
In my practice, I think only 30% of the patients would be fit enough to take or undergo autologous stem cell transplant in the relapse setting. So the rest of them would be either comorbid conditions or too early refractory disease, probably.
Has the very critical and the disappointing results of the Scholar study influenced you in any way? Yes.
So for that, sir, again the same thing, my first therapy should be so good so that the relapse chances are less. But definitely the chances of getting the second CR is little difficult.
So I'll put it another way. Would you choose transplant for all your patients who have relapsed?
Not all the patients. I will look into the duration of the relapse-free remission period. If it is more than 12 months, we consider it as a chemo-sensitive disease. Only those patients will go with the high-dose chemo, like RDAP or RIs, and then consider for the transplant. But only when they achieve at least a PR or CR. If they are a progressive disease, we won't offer any transplant.
Smita, you're an active transplanter in this thing, so yeah.
So the duration of DFI is very important. Should be more than 12 months. And the other thing is the patient, if it is less than 3 lines of therapy, salvage therapies, then probably the benefit is there.
Yeah. Okay. So the Scholar 1 study, which was very critically looking into the role of transplant in these patients, has yielded rather disappointing outcomes, except for a small subset of patients who have relapsed, who have had a late relapse in those patients, and also those patients who actually respond to primary treatment, chemotherapy, because as you see in the graph, partial responders do almost as badly as a person who does not respond to salvage chemotherapy. And even the responses that you get for a patient who has achieved a CR after a transplant, the median time to progression is rather disappointing over here. So it is less appealing these days. And so again, we come back to polatuzumab. So would you, if the patient can afford this thing, would you offer polatuzumab in all patients? And then think about doing an auto transplant subsequently. Yes. Santhosh can take it up, yeah.
So the data with polatuzumab relapsed refractory setting is with bendamustine.
Yeah.
I think the response rates were 30-40%. My practice as of now is not to use, especially in patients who are fit and I think would respond. I would just use R-DAP or R-ICE and take them to transplant and keep polatuzumab for in case post-transplant relapse or otherwise.
Yeah, okay. So, so this is what we have in outcome for relapsed patients with polatuzumab. There has been a thing, but it is one of the other things that it is the curve is always dropping over there. We are not having any plateauing of the curve in the relapse setting. So we need to do something more beyond that. But it seems to be a better way of approaching patients over here in the relapse setting. And maybe we don't have the data for transplant subsequently. So what about using newer monoclonal antibodies? I am sure that none of us have, including me, have not had the experience of using any of it, but this is purely purely theoretical and what the data that is present over here. And we have currently, so I'll just rush through this. So this is an antibody drug conjugate, just like polatuzumab, but it is a CD19. It targets the CD19 over here, and we have some good effects that we see with the use of this thing, as we did with, and this is in multiply treated with a median duration of response of about 10.3 months, which is again better than what we saw with polatuzumab in the same setting. So the role of cellular therapy and CAR T cell therapy, bispecifics, have we started embarking on those things in the institution?
All of us have signed agreements with the company,
okay.
And waiting for some patient to be ready to pay for it.
So when are you ready to pay for, who are the people who would you consider for CAR T cells? Where would you place CAR T cell therapy now currently in the relapse?
So we do have started CAR T cell program at our institute, and till now we have given 4 patients CAR T cell therapy.
Okay, good.
So we do consider at the patient for DLBCL first when the relapse is within 12 hours or it is primary refractory DLBCL, and second the patients who are failed on more than 2 lines of the therapy, we are offering CAR T cell therapy to the patients.
Any other? Yeah.
Post-transplant also, if the patient has, there also you can use CAR.
Yes, yes. So these are some of the major studies which I've just picked up over here, that is with lisacaptagene and also tisagenlecleucel, which is the 2 studies which have profoundly shown an impact in terms of sustaining responses in the relapsed refractory setting patients, even post-transplant. And these are some of the CARs that we have. I haven't included the Belinda study over here because that was a sort of a negative study, but they had its own issues because probably the number of CARs that, I mean, the concentration of CARs that was actually infused was much less over there, and also the patients had much more, almost 5 lines of therapy which they had failed. And then the other monoclonal antibody, tafasitamab, is also being, it is a FC enhanced humanized antibody like rituximab, and that is also in combination with lenalidomide has shown some fantastic responses in 81 patients who were enrolled, at least 1 dose or both, the median follow-up at 13.2 months, an impressive response rates over here in the relapsed refractory setting. I think my slides were closed, is it? Yeah. Okay, so I just wanted to also discuss about the bispecifics over there, and I think I'm overdue with the time over there, but glofitamab is one of the things that has come into the picture which has shown excellent responses, almost similar to the responses that we have with CAR T cell therapy, and probably that is going to come up in a more profound way in the future because it's off-the-shelf treatment protocols over there which can be used for effective treatment. And we have so many other bispecifics also, 3 of them, epcoritamab and also odronextamab, which is there, which is similarly, all are targeting CD19, I mean CD20 and CD3, and akin to the CAR T cells. So I thank my panelists. We are just run short of time, so I think we'll stop there. And that was the only thing that was to discuss, which is the bispecifics.
So group photo, sir. Thank you very much, sir, for a wonderful talk. I think you set the platform for next 2 discussions. One is immunoconjugates, that are hyper hope. The second one is CAR T cell therapy in India. So I think next 2 sessions will go on that, and definitely we'll have the more discussion on that. Thank you very much, sir, and thank you very much all the panel members for wonderful discussion. Next, we'll go to the next topic is again the era of antibody drug conjugates in the management of lymphomas. Hope or HIVE? I think is again Dr. Ganesh Jyotishwar. Everybody knows him as one of the senior most hematologists in the country, and he's a good academician. I think always, and he talks very nicely in the topics of all the topics from benign to malignant and all the new eras. So over to you, sir. So he's a senior consultant at Yashoda Hospital, High Tech City.
Good afternoon, everyone. At the outset, I would like to thank the organizers for this wonderful opportunity amidst the august audience. I can see the hall full, and it's really heartening to see so much of academics across our hemato-oncology spectrum happening in Hyderabad. So I had no conflict of interest for this talk. Of course, my family and my friends such as Dr. Nikhil. Just on a lighter note, before I start my presentation, you know, this is the place where I work. Most of my colleagues across the country thinks it is hype, but actually it is not hype, it is a lot of hope with active departments and realistic work going on. So in this context, antibody drug conjugates, when I was, you know, I must thank the organizers again for this wonderful opportunity to go through the literature. And I was surprised. The data about these ADCs is more robust, more promising in the solid malignancies compared to what it is happening where it originated in hematological malignancies. So basically, these ADCs were designed to address the limitations of cytotoxic chemotherapy. We all know the classical conventional cytotoxic chemotherapy has a narrow therapeutic index because of lack of tumor specificity, and the dose limiting toxicity eventually becomes the various organ toxicity, including hematotoxicity. So to overcome that, you know, the first concept, the proof of concept was put before by Paul Eldridge way back in 1913, even before when other chemotherapy drugs were not robustly present for the treatment of vast number of cancers. So this was a concept, and then these ADCs were designed to have an expanded therapeutic index because they are kind of targeted drug therapy. So this is the structure for our understanding. So for a specific target antigen, it's an antibody coupled with a linker, and the linker containing the warhead for destroying cancer cells in form of cytotoxic drugs. And that's how it delivers precisely the whatever cytotoxicity limiting theoretically to the cancer cells alone. Of course, the hope, because these antibody drug conjugates are the biological missile for targeted cancer therapy. And you know, it's again very heartening to see my talk being followed by CAR T cell therapy session by Dr. Rahul. So we are living in the era of these immunotherapies and you know, targeted therapies, which I feel is a surgical strike against various cancers, and for ADCs are lymphomas. Of course, we are not yet till there, because even though the proof of concept theoretically looks very promising, there are various limiting factors, the biochemical, the characteristic of the antibody, the linker, stability, and the payload, you know, its stability till it is delivered to the target cancer cells. These are all limiting factors, but we are slowly reaching there. So this is just for a basic understanding, structure and properties of antibody drug conjugate. In case of lymphomas, the surface antigens, which I highlighted down, the many possible potential targets, surface CD markers. So this antibody, upon binding to this antigen, which is carrying with itself the payload or the warhead, which can be various chemotherapy drugs, most notably tubulin inhibitors or DNA interacting intercalating drugs, which are inactive, which in a way it doesn't act at other cells while it is in the circulation, and upon binding of this antibody to the antigen on the lymphoma cell, it gets internalized and then it starts its effect exactly on this lymphoma cell theoretically. So there are various factors which determine this specificity, action, and sensitivity. Again, there are, as I mentioned, various biochemical parameters, the stability of linker, the antibody specificity, binding to the select targets, and this payload, you know, whether it is diffusing passively while in the transit or exactly it is getting activated once in the cancer cell cytosol. These are various factors which determine exact efficacy and specificity of this product. So these are by various ways how does this ADCs act in clinical practice. So essential, there are three basic, you know, end effects, either it is complement-dependent cytotoxicity, antibody-dependent cell cytotoxicity, or antibody-dependent cellular phagocytosis. So essentially, eventually leading to apoptosis of these cancer cells against which this antibody is designated at. So it is in a way precision medicine in lymphoma, and you can see the timeline starting way back in 1910. Till today there are 3 ADCs out of 12 approved for lymphomas, and the renaissance of ADCs is evolving, first, second, third generation, depending, each generation improvising its efficacy and decreasing its toxicity to the surrounding normal cells. So as I mentioned, there are over 160 ADCs are active in the clinic at various phases of development, of which 12 are approved, and of these 3 are for lymphoma. The hype is cancer create different ways to escape effectiveness of various chemotherapies, including antibody drug conjugates. So as I mentioned, the various characteristics, physical and biochemical characteristics of this antibody, linker and the payload, all these put together will decide whether this payload is exactly going to be active upon delivery to the target antigen. So these are various characteristics which determine its instability and thereby toxicity to other non-targeted cells. So in clinics, the first trial Echelon-1 published just recently in Lancet Hematology 2021, you can see on 5-year longer follow-up, brentuximab, which is anti-CD30 ADC used in Hodgkin's as well as T-cell lymphomas, and you can see upon up to 5 years, the curves are clearly segregated, even though not to the extent which we expected, but still there is about 8 to 10% survival benefit at 5-year timeline. So that's the reason why it is approved for unfavorable stage 3, stage 4 Hodgkin's lymphoma. Now coming to Echelon-2, this is all T-cell lymphomas including PTCL, AITL, ATLL, EATL and HSTCL. So you can see this brentuximab plus CHP versus CHOP, again at time point of 5 years, there is about 10 to 12% survival benefit with this brentuximab based combination, leading to its approval in these select T-cell lymphoma subsets. Again, the PFS as well as OS, the curves are clearly segregated, and they continue the segregation at 5-6 years timeline. Now coming to same brentuximab in Hodgkin's lymphoma, particularly the high-risk Hodgkin's lymphoma, the risk factors being either primary refractory or early relapse within 12 months, or Hodgkin's lymphoma with extranodal disease at the time of relapse. And if you see post-autologous transplant, those who were not on brentuximab versus those who were on brentuximab, you can see at 5-year time point there was 20% survival benefit, again leading to its accelerated approval in post-transplant high-risk Hodgkin's lymphoma subset. Again, in the DLBCL scenario, even though the numbers are not double digit, and you can see here there is about 7% PFS benefit with almost equal toxicity profile to the comparator R-CHOP. Even though this 7% single digit doesn't look appealing, but I will like to draw your attention that in a subset like DLBCL, the curative potential is 60%. What happens to remaining 40%? I'm sure Dr. Rahul is also going to highlight the same thing across the globe. CAR-T as well as autologous transplant, the curative potential in this relapse refractory setting is 40 to 50%. Right? So if you calculate that percentage by compounding, this 7% is actually 15 to 20%. So that is really worthwhile. So again, this advantage is not as great as the the landmark rituximab, which has clearly transformed the outcome of DLBCL with almost more than 30% improvement in the survival parameters. But yes, not up to this rituximab like of kind of intervention, but this 7% in current era still matters most. Now coming to ADC toxicity, just like chemotherapy, the toxicity is less, but it has own set of toxicity because of either the innocent bystander effect or specific target organ effect like peripheral neuropathies and ocular keratopathies. So between hope and hype, the current challenges and how we are going to overcome these limitations of ADCs, which were quite promising when the studies were originating in way back 2010 and 2011. So there are second, third, and various different generation ADCs with bispecific, dual payload ADCs, ADCs with immune stimulating payloads, radionuclide ADCs. Of course, they were not very initially with a lot of promise. They failed in the clinical trials like Javelin and Buxar, but there are novel, newer radionucleotide ADCs which are in phase 1, phase 2, which holds the promise of overcoming the limitations of first and second generation ADCs. So again, there is a huge rationale of ADC combining with various combination chemotherapies, chemoimmunotherapies or immunotherapies, and this is a hugely evolving field. And just to be precise, in lymphoma, you can see in hematological malignancies, chemo-based combinations in Hodgkin's as well as DLBCL, targeted therapy combinations, again brentuximab with various targeted therapies and immunotherapy like checkpoint inhibitors, nivolumab and the pembrolizumab along with brentuximab. These are the future ongoing promising combinations, so please watch this space. So again, just to highlight few of the upcoming data of these combinations, BV plus ICE, conventional salvage chemotherapy in relapse refractory. Contrary to the standard 60-70% response rate, the overall survival and the long-term progression-free survival is crossing 80-90% in these preliminary trials. Of course, again, nivolumab plus brentuximab, you can see the response rate is more than 90%. So again, you can see brentuximab, nivolumab combination, particularly after autologous transplant, contrary to standard conventional chemo, followed by transplant's curative potential 60-70%. This has raised to 91% with overall response rate of 85%. This is quite good. Again, elderly patients, unmet need. These are various clinical scenarios where these molecules holds a huge promise. Again, I will skip this. These are various novel, newer ADCs in the field of Hodgkin's and non-Hodgkin's lymphoma. So various phase 1, phase 2, phase 3 trials. Due to lack of time, I'll just skip it. But what is future? 50 years in making chemotherapies, targeted therapies, learning the right combination of successful ADCs. So target and antibodies, which will lead to efficient delivery of ADC payload. The various conjugation chemistries and linkers for overcoming potential off-target toxicity, and more precise payloads like topoisomerase, DNA intercalation cross-linkers, microtubule inhibitors. These novel second, third generation payloads are also coming into practice. So again, so where the future is going to lead us? Probably if we are putting our steps right in direction with robust clinical data, with all these novel, newer combinations with new payloads and new linkers, it has a huge potential of replacing the toxic conventional chemotherapy. Again, indication and target biology driven ADC design, proteomics, and this is a new upcoming field, and also the combinations and various sequencing, either combination or sequential immunotherapies or conventional chemotherapies with ADBs to overcome resistance. This is again an upcoming field. So there is lot of things, lot of trials going on, lot of, of course what we are seeing is the tip of the iceberg, but how we look at it, I said 7% for many people, they will say this is, single digit numbers are not very appealing. So it's how you look at it. So hope or hype, I feel there's a lot of hope, and looking at the evolving literature, the ADCs have a huge potential of replacing lot of conventional toxic ineffective chemotherapies across the vast lymphoma spectrum. So again, this is not goodbye, but a see you soon sign. So stay tuned to this space, including non-Hodgkin's lymphoma like DLBCL. So this is a time to change our approach to offer the best possible chance of cure survival across the lymphoma spectrum by these targeted agents. Thank you so much for your kind attention.
Thank you very much, sir. I think wonderful talk. I think you have covered very nicely, and your slides are very, very good actually for all the students here. Definitely they can understand better what is the etiology, pathogens, mechanism of action. I think all your slides are very good. If you are willing to share, I think we can share to some of the students, and it can be useful for each and every student, I think, okay? If you agree on that,
yes,
okay?
yes, yes.
So any comments on this topic? No? And there definitely is a hope. I think everybody agrees there's a hope, not hype. Maybe the combinations may be better in the future.
Audience reaction, it looks like hype, but I'm sure it is hope.
No.
Thank you.
Don't think in that. Of course, because we have all the drugs. I think we should know where to use that one, how to use that one, the sequential or combination, and toxicity also. We have to take care of the toxicity also important, and outcome. Of course, efficacy versus toxicity, that's the main goal of any oncology. And the next talk, I think this we missed some of. He's sorry. Prashant. Now I think we'll go to Prashant. Yeah. The name changes because Rahul Parwar is not there, so we are going with Dr. Prashant Mehta on this role of future of CAR-T therapy in India. And anybody can, I think most of us, they have some experiences, they can share. It's something like a sharing experience in Indian context than in a single talk. So anybody can comment, anybody can contribute
Absolutely,
to this
so
talk.
this is more
Thank
of
you.
experience sharing probably. So Professor Purvar could not make it today. So this is, just a few slides to arouse interest actually. So this is all the approved CAR-Ts we have right now. And for, ALL specifically, we have TISA and Brexu. Brexu is basically a refined axi-cell, nothing, very different. And for the lymphomas, we have all these 4. And recently, LISO also got an approval for CLL. ID and SILTA. ID cell and SILTA cell are for the myeloma space, BCMA CAR-Ts. So most of these are, 41BB, but Axi and Brexu are 28, which are more toxic, rapid onset, more CRS, and they have, rapid peak and less persistence. Although the persistent doesn't mean that less persistence doesn't mean that they have, lesser durability of response. So let us start with a few questions, which is again to arouse interest, and also it has some meaning in the subsequent slides. Which Indian CAR-T is now market authorized? Actellicel, Varnim-cel, both or none? C is the answer, yes. So Varnim also, the immunil CAR-T also just got market authorization in the NHL space only, not ALL as of now. And they will need the state FDA also to get across, and be commercially available. But yes, these two are approved. Again, another MCQ, which CAR-T is approved as second line, versus SOC in the DLBCL space, who have progressed within 12 months, Axi, Liso, TISA, Axi, Liso, TISA. Anybody? So the answer is, because Professor Menon also mentioned that Belinda actually failed. Transform and Zuma 7 actually it worked. So TISA cell no, but Axi, Liso yes. So D is the answer. What is the long-term survival of DLBCL with CAR-T cell therapy? Relapse refractory space. B is the answer, 40%. This is a salient finding from Zuma-1, ORR 83%, CR 58%, disease-specific survival at 5 years 51%, OS 40%, 64% in those who achieve CR, and duration of response is 34 months. ICANN 64, CRS practically everyone, fever everyone, 11% grade 3 and above, 30% ICU admissions, about 10% on ventilator. Which of the following statement is not true about CD20 bispecific antibodies in development for DLBCL? Like glofitamab. So what is not true regarding these? Complete response in 30-40%, did not show efficacy in prior CAR-T, CRS observed in half or more, step-up dosing is required. Anybody? So B is the answer because they have actually been utilized. 40% of patients in the glofitamab study were actually post-CAR-T. Same is true for drugs like Tafalen. Which of the following statements is not true about Brexu cell and mantle cell? So Zuma 2 CR 68% did not show efficacy in high risk, PFS nearly 4 years in those who achieved CR, or PFS only 3 months in those whose best was PR. I will answer this. It actually did show efficacy in high risk also. And so, that is the incorrect statement about Brexu in mantle cell. Follicular lymphoma, the only difference is some of the PRs at day 28 or day 90, they do convert into CR. That is not the same for mantle and DLBCL. DLBCL PRs don't convert mostly, and those turn into PD. The same is true for Actellicel in India. So as per a recent update again in the myeloma space, BCMA CAR-Ts, the recent ODAC presentation. This actually presented to the FDA, actually, this data. And this will actually lead to ID and SILTA approval in the 1 to 3 line space, not the pentarefractory. So this is earlier approval for ID and SILTA OS is better actually, versus SOC ID did not improve OS over SOC, so ID will not get the approval this time, and it will actually be regarded as an inferior CAR-T in BCMA space. These are the other BCMA targeted drugs. We have bispecifics. What is the advantage? They're off the shelf. The cost is similar, but they require repeated infusions as regards the CAR-T, which is a one and done therapy, but not so one and done because there are long-term toxicities also. And now we have second primary neoplasms, MDS, AML, and whatnot. So there is other factors coming into picture here. So also, getting a slot for leukapheresis, delays associated with CAR-T, that also puts CAR-T slightly, in a difficult space in some situations. So important, why did I show all these slides? You saw every CAR-T is different. The approvals are different. Actelicel is an Indian CAR-T. They have tested in a specific subpopulation. We can't cross-utilize everywhere. We can't say we will use for POD12. That's not the place they have been tested. So do not cross-utilize. TISA did not work in the POD12, but AXI and the LISO worked. So those are approved, but TISA is not. So use the car on the road which it has been designed to traverse, else our ride will be very bumpy. Toxicities are different for the HCAR19, which is a humanized CAR-T, and it causes much less CRS. I'll show in subsequent slides. So see, it's a CD41VB CAR-T, which is again, makes it less toxic. Indian CAR-T, this is the, amazing group which has led to this amazing invention in India, and we must thank all of them, must congratulate that they have done such amazing work for our country. This is the phase 1 and 2 clinical trial summary. All the patient dosed, BALL about 75% MRD negativity, that's the latest update. B lymphomas, 44% CR rate, 65%, latest is 40% CR, 70% overall response. And that is the data of responses only. Durability we can't talk much about right now. And this is comparison with other FDA approved CAR-Ts. ORR 68, Acteli is the Indian one, TISA 50%, AXI 83, LISO 54%, cross trial comparison. But this is what we have as of now. And CRS was, 38 patients, 67%. ICANS hardly any in the Indian CAR-T. So there is where it scores, it is not a toxic CAR-T. It doesn't cause much of problems. This is the, lymphoma cohort. CRS more than grade 3 was 3 or more is 0%. As compared to the other approved CAR-Ts, which is high grade, CRS is very common. This is again comparison with the other FDA approved CAR-Ts. Leukemia cohort, CRS grade 3, yes, it is there because it's expected in leukemia more. So 20% in the Actelicel versus in others about 70-80%. Other FDA approved products. ICANS hardly, it's nearly negligible in the Indian CAR-T, but yes, it is there in other approved CAR-Ts, the Western CAR-Ts. It is a significant problem there. So ICU admissions also with Actelicel only 7%, with AXI 25%, TISA 47%, in Juliet that's the lymphoma cohort 24%. So it's a safer CAR-T to use. IVIG support was used very often. About in 40% of patients, IVIG was given in the NextCAR19 study. TISA did not report. Brex also gave 11%. The cutoff they used was 600 milligram per deciliter of IgG, and they gave in about 39% patients. So that's an additional cost which needs to be discussed with your patients, with our patients when we are planning CAR-T. They need to be aware of the recurring costs of such infusions. So it's not one and done. This is a scenario from our center. We have just completed 5 infusions, and this is a lady who had this MYD88, which I do test for MYD88 and 79B. It helps me decide some treatments, especially the bridging therapy. I use Acala-Len in such patients, and she actually did stabilize after Acala-Len. She was in PR kind of situation because she was chemo-refractory, R-CHOP refractory, and she actually had a CR to Actelicel. So this is one such patient. Immunil also coming in a good way, and they have their murine CAR-T, and they are using a Spanish lentiviral vector, and theirs probably has more toxicity as expected in a murine preparation, and what they have done to reduce toxicity, they have fractionated their doses into 3 components, 3 days. So that's how they reduce the toxicity. So the responses, and there's a summary slide, 76.5% ORR, BLL 75%, and in the lymphoma cohort also 90.9% ORR, pretty brisk CAR-T, and the CRS 4.3% grade 4. There was one mortality due to CRS. So some more toxicity is there, but with the fractionation, they have been able to manage. Velour experience, Dr. Uday shared this in SACT meeting. They have dosed 8 patients, DLBCL 1 CR, 2 responses were not reported at that time when I saw this presentation, and ALL 3 out of 5 were MRD negative at day 28. That's the update I have. So CAR-T or ASCT, very interesting. So Professor Menon already showed that ASCT there for some subsets of patients who actually have early progression, how it fares. So this is data from CIBMTR that 5-year PFS for early chemotherapy failure or late chemotherapy failure, if they are in PR, it is okay. You can transplant these as per this data at least. So some of the chemosensitive relapses, even POD12s can be autografted probably. So this is Professor Dr. Hari administering the first BCMA CAR-T 3 weeks back. I've taken this from LinkedIn, and he's one of our mentors. So just amazing days for our country that such great scientific progress is being made. Not only the CAR-T space. This is science progressing in India, which is just so good to see. So what is my take home for Indian CAR-Ts? I think CAR-Ts have finally arrived in India, but we should not hype it. We should just talk about it like any other treatment. It is an option. And to our patients also, we should tell that this is a treatment option. These are the pros and cons. These are the response rates. This is the durability. This is the cost involved. And it should be a balanced approach. And feasibility and long-term efficacy of Indian CARs is to be proven yet. There will be a learning curve. And indigenous CAR-Ts are cheaper, but still nearly inaccessible to many patients. In the US also, the accessibility to CAR-T is very poor. So India will take time to get anywhere with CAR-T. Awareness about the patient selection, toxicity and management would be crucial in India. And transplant, we should not let it go. And it is a strong option still for many patients. And what are my indications as of now for Indian CARs? Because I can't cross-utilize. I showed you slides where every CAR is different. You can't just go ahead and use in any indication like POD12. Chemorefractory DLBCL is my indication for Indian CAR. Post at least 2 lines, post auto-relapsed, yes. But I would not like to use it in chemosensitive relapse in transplant-eligible patients, because that's not where it has proven superior to SOC or to transplant. So polatuzumab has come in India, and now it will probably change the dynamics of CAR-T use in India, as it will also reduce the POD12. And also, you see, many of these patients would be who relapse would be ABC type, and ABC you would be utilizing Pola more. So we would find lesser candidates for CAR-T with Pola entering in a big way. I think it is making inroads in many of our, the use is picking up. What are my indications for Indian CARs in ALL? Refractory BALL, yes. Relapsed post-allo, yes. Bridge to allo, whenever feasible. But other options are also there. We have those, immunotherapy drugs, and Blina, wonderful drug, Relapsed transplant ineligible, yes. It is a place for using CAR-T as a curative or definitive treatment. But I would not like to substitute for allo as of now. We don't have the resources to do that. We don't have the know-how to do that. We are not doing NGS-based MRD. Our CAR-T has not proven in this space as of now. So we need to be cautious, but it's great that we have it. Thank you.
Thank you, Dr. Prashant. I think wonderful talk. I think you are the quiz master, and you are also the answers also you have given. So good thing, I think, because most of us there we are learning at the curve. And sir, any other comments from the experts? Menon, sir, anything? The Indian scenario, CAR-T therapy. Want?
Necessary that always all the CAR-T cells that we manufacture is going to work. What we don't know, we have seen only the success. There are so many other companies who have actually manufactured cars which have not seen the light of day because there has not been a sustenance, there has not been an expansion, and also sometimes there has not been an ability to manufacture it also. So I was just, last week I was discussing with Hari Parameswaran, who was one of the first people to start CAR T cells. So he was just warning me about this particular, which is not discussed actually. So it's not that the fact that you manufacture CAR T cells and it's going to be successful when we actually give it to the patient.
And Dr. Purish Parikh, sir.
So since Hari mentioned what is not mentioned, I thought of another point that is not mentioned, and that is second malignancy. Yeah, nobody talks about that.
Yeah.
And I think that is something that we have to be really concerned about.
Yes, 4.3%. Yeah, absolutely.
What is the percentage of aplasia, and how difficult was to manage?
So you're talking of my experience of 5 patients?
In fact, anybody who is in this house.
In the ACT data, B-cell aplasia, I think they achieved B-cell aplasia in about 60%.
60?
Yeah, 60%. 60% had durable, aplasia, and people, they have about 6-month data of that, I think. Yeah. B-cell aplasia definition is also a concern because defined differently in different studies. They use flow actually, monthly flow, I think. Yeah.
Any other comments or doubts? I think we are hoping for the best. I think definitely. I think this again we have so many hitches and something.
Absolutely.
But patient. Again, but whenever you are planning to something CAR T therapy, I think you said something. Some of the immunoconjugates you are not supposed to use before the CAR T. For example, Pola something, CD22 or CD19 monoclonal antibodies. If you use that one, you can't use the CAR T therapy later, no?
Yeah, if you use glofitamab upfront, then there is no data for using CAR T, less data for using it.
So I think
glofitamab can be used after CAR T.
Yeah.
So
one thing is I think you have to sequence things in a better way than something.
The sequencing would be important.
Yeah. So thank you once again for this wonderful talk. I think you rescued this talk. Yeah. Next. Yeah. Thank you. Again, this Golden Jubilee Icon Conference, I think, so especially in Hyderabad, the city of this, pearls, so happening here. Now, I would like to invite Dr. Uday Anamandra. I think everybody knows him as something. He's a main pillar of this Indian myeloma academic group, the IMAGE. So he's very active. At the same time, he's a main pillar and he's trying to collect the data and presenting myeloma data in various conferences. Now I'd like to invite him to moderate this session. I'd like to invite the panel members, Dr. Narendra Kumar Tota, and he's a consultant in KIMS Hospital, Hyderabad. Dr. Ritu Jain, medical oncologist from Mumbai. Dr. MVR Narendra, hematologist, and he's also from Hyderabad. Venkateshwar Rao Paidi, he is a medical oncologist from Vizag. Dr. Deepa Susan, medical oncologist from Velo. And Dr. Suman Kalyan, a medical oncologist from Chennai. Dr. Rian, Uday.
Firstly, I would like to thank the Team Icon for giving me this opportunity for standing amidst oncologists, wherein hematologists are a small component. Oncology is our big brother, so it's like a big brother feeling always that what we have for you people. But yes, in this country, the hemato-oncology has started thanks to you people, and it has actually reached this stage thanks to the oncologists. So just give me a second. I think there is some technical glitch. There is I think the laptop takes a minute to start. But in the meantime, I could like to introduce my panelists for the day. Today we are going to discuss about, in 2024, how are we going to treat myeloma? So what's there? What's new? Yes, things have changed over the last couple of years, wherein we don't treat like age-old with just a proteasome inhibitor or with the IMID in combination with steroid. People are doubting, should we give steroid at all? People are doubting, should we do transplant at all? People are talking with now the bispecifics going to come in our country in another 5 to 6 months. What should be the sequence of therapy and others? So we are going to highlight about few aspects. We are going to take it from smoldering to newly diagnosed to that of the relapsed refractory setting. So we are going to do that, and we are going to discuss in these 3 things. And for this, I have got Dr. Narendra with me, who is a medical oncologist from Hyderabad, Ritu Jain ma'am from Mumbai, Dr. Narendra, ABMR Narendra sir from Hyderabad again, Dr. Venkateshwar Rao Paidi from Vizag, Dr. Deepa from Vellore, and I have got Dr. Suman Kalyan from Chennai. So that is the team that we have. You have to just give me a minute more because it's yet to start. There's some problem, it's restarting the whole thing. So we are going to have this. So maybe till the time the slides start, I think we can still start off with a thing. Okay, with the panelists, and Santhosh sir, we will involve you also in the panel discussion. So currently with the myeloma, the way the myeloma is progressing, earlier we used to define as MUGUS, followed by smoldering, and then shifted over to newly diagnosed. Where do you think is this barrier or this defining thing? Is it getting blurred? So what do you feel like, Dr. Deepa? How do you feel that what's happening to the current way? The things are progressing philosophically. So where are we going up to as far as the treatment is concerned?
Okay, sir. Thanks a lot, sir, for this opportunity. Right now, I feel myeloma has become like running a marathon or like running a race, and it's not a 100-meter sprint. So it's like one person handing over to the next. And earlier we used to think that it's a continuous spectrum from MGUS to smoldering to active symptomatic myeloma. And when I have a patient walking, suspected myeloma walking into my OPD, there are 2 questions that I dread. The first question is the patient asking me, for how long am I going to live? And the second question is, when did this whole process start? Both are questions for which, as an oncologist, I don't have an answer. And I'm sure most of my teachers who are here also may not have a direct answer to give to each of the patients. And the way I would look at each patient is, I would like to do the 3S and the 3E. S for the symptomatic myeloma, the second S for staging and risk stratification, and the third S is for stem cell transplant eligibility. And I would look at the 3 E's, the first E, the evidence, wherever you look at, and more important would be the second E, which is balancing the evidence with the experience of the oncologist, and the third E would be most important, the expectation of the patient. The 3H, H is the head, which is telling us what to do, the evidence which sir would be projecting. The second H is the heart, which tells us why we are doing it, and the hand, which tells us how we are going to treat the next patient.
Okay, so in the current era, what do you think? Should we manage or treat smolderings, or should we just observe as what we used to do around 5 years back?
So in the current era, when you have a smoldering myeloma, earlier what we used to think, MGUS becoming smoldering, smoldering becoming myeloma. But now we know that there is risk stratification of smoldering myeloma, the 2-20-20, which we all keep learning. When you have more than 2 grams of M-band, more than 20% and more than 20 in the light chain ratio, you have all the 3 factors, you become a high-risk smoldering myeloma, where your chance of progression and developing a complication is more than 90% in the next 5 years. So the way I look at it is, if I see that my friend is very depressed, is very anxious, his plan is having suicidal tendency, and is trying to climb up a cliff. What we used to do in 2014, my dear mentor sir is sitting in front of me. Till my final year, when 2014, the guidelines changed. Till that time, our attitude was, you find someone depressed who is climbing up the cliff, thinking of committing a suicide, you will not do anything. You will just look and watch, wait for him to climb up the cliff, fall down, and then you come with an ambulance and take him to rescue. But now, science has progressed, oncologists have become smarter, and in 2014, I think a few weeks before our exam, the slim came in and we were all busy mugging it up without knowing the sequence of it, the consequence of it. But now, 1 decade later, now I've realized that as oncologists, we have become smarter. We don't wait for the person to climb across the cliff and have a myeloma defining event. We get smart and we treat them early. And like for any malignancy, early diagnosis and prompt treatment would be the way to go. So why in myeloma we should think different? And about whether you need to give all the 4 drugs as a quadruplet for a smoldering, I don't know. We have evidence for maybe len with steroids, and the rest is, as I said, about expectations and the experience of the oncologist.
Okay, wonderful.
Whether we can cure early.
Nicely put, and this idea of cliff and other things is really very nice. I never knew, Hari sir, you used to take psychology classes also for your students. So, but good, a nice way of explaining things, but good. So, can I have any of the panelists, other panelists, talking about how do we like to prognosticate SMM patients on today's date?
Most of the points ma'am has covered. Only thing is, I think 2 out of the 3 is enough to treat now, as I understand. And again, it's the same from my student days to now. We are as you told, the line between treating and non-treating is very bleak now. So we are including smoldering to treat. I think 10% progress in first 5 years, if I'm not wrong. So those patients we used to observe, now we are treating. It's not because drugs are available. I think because results are available. So I would be treating smoldering. That's a change I've made in the past 5 years.
Wonderful. So, as rightly brought up by the panelists, so let's close the first part of it. Smoldering on today's date, we don't wait for the target organ damage to take place. We initiate therapy. What therapy? Totally depends upon multiple conditions. How closely are you able to follow up the patient? What are the finances of the patient? Is the patient under regular follow-up? Patient having good caregivers or not? Various things. And as far as the literature is concerned, let me tell you, as far as the smoldering is concerned, there are data or trials which are presented in this year ASH, wherein CAR-T therapy in smoldering has also been tried. Leave about myeloma, newly diagnosed myeloma. People have gone to that extent. Leave about quads. They have also started talking about giving CAR-T therapy in these patients. So that's as far as the smoldering is concerned. Now let's get on to the next part, that is newly diagnosed myeloma. There is a symptomatic newly diagnosed myeloma that we have. And this particular patient comes to you. Broad question, everyone wants to know. Quad, no quad. So quadruplet or no quadruplet? Narendra sir.
For a good risk patient or intermediate risk, I will go with triplet therapy.
Triplet therapy, sir? Sir, okay. Sir, wonderful. On today's date, there is nothing right or wrong about things. So, why not addition of daratumumab upfront?
I think the response and other things are good, but I think the long-term overall survival and PFS, I believe, whatever I have read, I think still more data required for the using in at least in a good risk patients about daratumumab, adding daratumumab.
Fine. So can I have the people to scan the codes, because we would also want to find your opinion about it, so the panelists can actually explain you why this or why not. So can I have everybody scan the codes, please? The scan code. Yep. So this the next one can take. So we have a 51-year-old asymptomatic woman, M protein of so-and-so, FLC ratio of so-and-so, Benz-Jones proteinuria, bone marrow biopsy showing 28% plasma cells and translocation 414. CT was negative and there was only one focal lesion, labeled it as smoldering. And case B, same picture except that the imaging had got lytic lesions and we have labeled it as active myeloma. Now I'm showing you these two cases which were actually presented in International Myeloma Society conference at Athens, and all the experts on the stage from Branduri to Dr. Vincent to Dr. Shaji were asked, what do you feel out of these two patients? Which one would be the one where you would like to treat, which one you would not like to treat? So can I have anyone answering? Ritu ma'am?
See,
okay.
For smoldering myeloma, there's already data. The Spanish study, Petima study, says that if you treat these subset of patients...
No, so the question is, out of the two, do you feel both of them are same?
Yes.
Or one is worse than the other?
This is active myeloma because you have a documented lytic lesions with the basic requirement for the diagnosis of the, of course, the myeloma protein of 2 grams, ratio of 25. But the lytic lesions confirms it is a active myeloma disease. So definitely this subset of patients require active treatment.
Okay. So you feel that the thing. Yes, ma'am. Ritu, ma'am.
This
is what the audience think about it. Okay, you can go ahead still with your interpretation.
No, going back to your further smoldering myeloma, she's in the high risk translocation if you see the cytogenetics.
Yes.
So that's concerning for me. I wouldn't be worried about the active myeloma patient. What is her cytogenetics?
Ma'am, 13q deletion.
It's not available. So with this data, I would definitely be more worried about the smoldering myeloma patient rather than that patient.
Okay, fine. So you have seen two panelists thinking two ways differently about which is worse out of the two. But let us put it this way. The same was even in IMS. The French thought differently, the Italian thought differently, and the Mayo Clinic people thought differently for the same set of cases, and everybody had different answers for it, which works better or which works poorly. So the point to bring about is its perception levels of what we feel and what we read about what it is. But at the end of it, the consensus was both of them are equally bad. It's not that one is worse than others, and both requires equal therapy. Okay, so then we talked about this. I'll not go into the detail. So which are the following strategies for people smoldering myeloma? This has already been discussed. So the type of progression in the smoldering, and also should we start treatment or not? We discussed this. And what are the various ways of identifying the high risk groups? So earlier we only had a Mayo classification. Then thereafter came in the Spanish classification, wherein they added over and above the Mayo classification few additional features. Then came in the IMWG 2-20-20 rule. This was the one which stayed for the longest duration, and the maximum studies were done based on this particular criteria of defining which particular type of smoldering required therapy. And then recently, we have got additional, as Ritu ma'am was saying, high risk cytogenetics, genomic profiling, the MRIs, the circulating plasma cells, everything came in, and people then started saying we require early intervention, treat early, and it all started only with LEN, followed by NEGM publication Lendex, and now we have gone to the stage wherein we have got various types of therapy from elotuzumab to ixazomib to KRD to also a CAR-T therapy for these things. So coming to the smoldering, so the summary of smoldering is if there is high risk, whichever criteria that you use, you start the patient at least on an IMID or an IMID with steroid, and if the patient is low risk or the patient is intermediate risk and you are able to observe, you are able to follow up the patient in such situations, go ahead and observe. Now, this was the second case, so we will start off from here. So the next panelist in line can take on this. The 60-year-old male presents with bone pain, and these are the various clinical features that you have. Finally, I have given the summary. It's a symptomatic multiple myeloma, ISS stage 1, RISS stage 1. What would be your treatment choice? Even the audience can answer it in the meantime.
Currently, I am practicing VRD followed by stem cell transplant and then LEN maintenance.
Okay, fine, taken. Why not others? The audience are so good. They are taking clues and writing the first answer. If I say the second one was the right one, so yeah.
We have data for DARA or CD38 monoclonals with triplets, that is quadruplet regimen, and it has shown good deeper responses and PFS benefit. But I am concerned about Indian setting that we don't have all the drugs which we read theoretically. We have a limited armamentarium with us and we should use it cautiously. That's what I feel.
Take it. Anybody who differs?
Sir, given the chance, if I live in utopia, I'll be giving for all the
quadruplet. Okay, I agree with both of you, totally. So now, the rationale, what they were trying to explain was, first of all, in a standard risk patient, multiple myeloma, irrespective of what ISS staging is or what RISS staging is, the current data suggests giving quadruplet therapy, period. But now, you need to apply these Western rules or the guidelines into Indian context. One, patient is not affording VRD, where do you add DARA on the top of it? If you give DARA upfront, will he be able to afford the transplant tomorrow or not? the given government, the various schemes which are there, will they cover DARA or not? So multiple aspects which needs to be put in, and you need to put that into Indian context and think about it. But scientifically, you can give a quadruplet as was also labeled, but keeping in Indian context, we can just give VRD followed by transplant followed by LEN maintenance. That remains the drug of choice. Now, treatment of choice. The most important point which needs to be driven home is, irrespective of DARA entry into the market, transplant still remains the backbone of myeloma therapy. Transplant is not going anywhere, irrespective of CAR-T coming, DARA coming, or the bispecific coming in another 3-4 months. The transplant remains the best option to give the OS benefit. So that's as far as the NDMM is concerned. And also for the students who are here, the classifications have changed. Now there is stratification. Earlier it was 2.0, 2.5, now it's 3.0. So we use the MSMART 3.0 criteria for diagnosing high-risk categories. And we all started with RD versus VRD. Then we started DRD versus RD. Then we went on quadruplet versus triplet. And then we went on, people said, why not DARA VRD versus VRD? And at the end of it, people have clearly shown that DARA VRD is better than VRD as far as science is concerned. Now the next question comes to the panelists, that theory is different, and as one of you said that we can't just apply to the Indian context. Do you think that the real world experience is same as that of the trial data? Because all of us have been given DARA for some time now. So how many of you don't agree to this? Wherein you say that the real world experience does not mimic. Because as far as the trial data is concerned, it's clear cut. It shows as if like R-CHOP versus CHOP sort of scenario. So wherein they say DARA VRD is the panacea. You can't give VRD is the way the data has come in over the last 4-5 years. But does the real world data emulate the trial data? Anyone?
I think you're not able to continue maintenance in the real world setting.
Excellent. First point. Narendra sir, any other point that you want to add?
I have not used much data, few patients only. So I don't have much data, I would say.
Ritu ma'am?
I have used in very high risk cytogenetics. In like this case scenario, I would not use still because cost is a major issue. But whatever limited experience I have in high risk, they have done well. In fact, one patient, ultra high risk cytogenetics, elderly lady with a lambda of 1 lakh. I've never seen a lambda of 1 lakh. A complex cytogenetic, almost triple hit. And for some reason, she couldn't continue the treatment. And after a year, she came back. I gave her 8 doses and I was planning for auto BMT. After 8 doses, she was in a complete remission. I didn't do MRD. But after a year, she continues to be off therapy without and in a remission. So whatever limited experience I have, it's a good drug.
Wonderful. Yeah, you wanted to add something.
I have used in 3 patients. 2 of them went for transplant and they're doing really good. One patient is elderly patient. He's started with LEN, but he had reaction, so I need to change to DARA with pomalidomide with very low dose. So, but this patient and single drug right now, he's doing really well. Almost he's crossed 18 months now. So I feel personally, if the cost is not an issue, DARA would definitely make a difference. That's what my personal feeling.
Hemant sir, your opinion, because in Rajasthan it's free of cost. So what do you feel that the government of Rajasthan provides it DARA free of cost to all patients?
So, Uday, there's nothing free of cost in this world, right? So, that DARA, if it is really indicated, then yes. If it is borderline indicated, then it is coming out of your tax money and my tax money. And then, roads are not being built. Now the government is in a situation they don't have money to pay salaries and everything is stopped. So you have to kind of balance that. But my personal feeling is that for a low-risk patient who requires treatment, you do the 3 drugs, do the maintenance, and when there is a recurrence, then you do the next level of treatment. 38. If you use it up front and the patient recurs, you're not going to cure him. So smart sequencing is what we have to understand, and you have to balance the costs in the... I'm like a conservative oncologist.
Oh, no, I'm totally with you, sir.
So that's
sir,
what
our approach is also the same. Though in army, we totally get it free of cost, but I totally agree. There are no free lunches in life. Somebody is paying for it. So now, anyway, I'll summarize these points into 3-4 points. 1, it's not that because you have it available in your cupboard, you give it to everybody and everyone. And why I ask this question is the real world experience really does not emulate the trial data. Though the trial data says ki best and everything, we have seen enough number of patients who relapse after daratumumab, and in Indian scenario, without having any further lines of drugs or lines of therapy, we don't know what to do, number one. Number two, in a civil setup, the most important aspect is the trial says give it till transplant, post-transplant, give it for maintenance for so many months. Is it possible for a patient to maintain and having so much of financial burden on him to continue so long? Doesn't happen so. And most of the times it happens that the patient stops it or abandons it in between. And then we say because he abandoned, that's why the patient relapsed or whatever it is. So one, in our country, we are not really able to emulate the trial data because of financial constraints, resource constraints, and also for the fact that patients, the type of immunity and the infection load that these patients have is very different from the Western data. So I agree with that 67% of the people and the panelists saying that it's not that you give it to everyone, but yes, wherever there is a high risk cytogenesis, and as I said, smart sequencing is what is important. So let's go on to the next part of it. This is as far as the treatment guidelines of how we go about the thing is concerned. Now if you see, even the guidelines say in standard risk, either VRD or a quadruplet. They have not taken out VRD from the guidelines. It's still there, the triplet is still stands there. So triplet followed by transplant, followed by maintenance. And particularly those patients where you want to do a delayed transplant, you have to give limited cycles of DARA, not DARA for time immemorial. So that has been clearly brought out. And in high risk cases, definitely there is a role of giving the patients daratumumab or quadruplet. Now in those patients who are transplant ineligible, you don't find actually a DARA with VRD or a quadruplet through and through. So again, in transplant ineligible, it's wishy-washy. So that's where we are. Now lastly, coming on to quickly in the last 5 minutes about relapse refractory scenario. So to the panelists, we portray a case of 64-year-old female with B and A being positive in the CRAP criteria, IgA disease, 41% plasma cells. There was no high-risk cytogenetics upfront. The patient underwent PET, found diffuse bone lesions. So because I didn't find any high-risk cytogenetics, I gave triplet. Followed by that, we gave transplant with MEL200, followed by LEN maintenance, as has been discussed and agreed by the complete audience also. 3.5 years from the start of maintenance, now the patient relapses. Patient has now again got a bone disease. M spike has risen quickly within 2 months from 3 to 10 gram per deciliter. What would be the next line of therapy? Because the patient has been exposed to proteasome inhibitor, to IMID, and IMID maintenance, what would be the next line of management? So,
whatever the drugs you have used, I think we should go, I think I'll go with the KD and daratumumab followed by transplant, because 3 years he had a remission. So KD followed by transplant.
Anybody who wants to give something different other than KD Dara?
You can add A and B, I think. Isatuximab also you can use.
Okay, fine. So you want to give isatuximab, that's perfectly okay. Anybody different? So I agree with the panelists. So what they have been trying to say is based on 2 trials, that is Candor trial and IKEMA trial, either you give a combination of KD with DARA or you give isatuximab with KD. So both of them are good options. But please remember, where a patient has already got an IMID, even if it is one IMID, giving, earlier we all used to do, we used to change it to pomalidomide. Now the data has clearly come up saying that if you have given one IMID, particularly for a maintenance duration, adding one more IMID really doesn't help. So that is something which needs to be remembered. Now, this is what we were talking about, wherein CAR-T or bispecific antibodies, and we were saying that by adding these particular things, the things would change over a period of time. So let's look at your options. If a patient has relapsed, multiple relapse refractory, what would be your ranking as far as your choice? What you would give first, what you would give second, what you would give third? In the meantime, any other panelist, one of the panelists can take it on. Yeah, please.
If the disease is slowly progressing, there's a time, I'll go for CAR-T.
Okay, fine. Anybody else? Any difference of opinion?
Nice point, sir. Even because we have a time, waiting time. So CAR-T has the best results, and bispecific are very tempting, but we don't have it now. So
okay,
that will be the sequence.
Now I'm really surprised about ADCs coming up by the audience. So anybody, any comments on ADCs? Currently the role of ADCs in myeloma, because the previous talk by Dr. Ganesh was so good, now everybody is answering ADC, but is ADC relevant in myeloma? So please let me tell you, ADCs on today's date, the recent data, melflufen and the ADCs failed thoroughly. and they have been withdrawn from the market as far as the US market is concerned. So in US market or the current trials in the last 6 months, it's only bispecifics and CAR-Ts. The others have actually gone out of vogue. So with that, yeah, we can have this question. So a 69-year-old female, KD is cetuximab, the same lady, let's take. Best response VGPR after 6 cycles, MRD positive. After 20 cycles, new bone pain, M spike, bone marrow aspirate showing 25% plasma cells. Patient is 69-year-old, please remember that. And patient is triple class exposed and triple class refractory. What would be the next choice of drug? Would you like to give bispecific or CAR-T out of all of them? Even the audience can answer in the meantime.
Bispecific. You need a faster response of bispecific.
Wonderful. So any difference of opinion as far as that is concerned? So the bispecifics are going to enter the Indian market very soon. So when you want a quick response and you do not have time and you are seeing that the patient is rapidly progressing, then the bispecifics remain the answer. If you feel, as was also told by the panelists, that it's a slow progression, then you can actually try a CAR-T. Quick question, bridging therapy. If you are thinking of a CAR-T, would you like to go ahead with bridging therapy? Another 20 seconds. So bridging therapy, would you like to take on for a bridging?
Depends on the response with current regimen. Maybe if she has a stable disease, then we need not add something else. We can continue the same regimen and then go ahead with CAR-T.
Fine.
And also, one more point to add. So once we do ADC, how well would CAR-T perform post-ADC?
Very good. Yeah, that's a very important point, which I'm going to show it in the last 2 slides. So now, as far as the bridging therapy is concerned, for patients waiting for CAR-T infusion is an important consideration because it has been clearly shown pre-CAR-T, the depth of response dictate the post-CAR-T improvements, both the PFS as well as the OS. So it's always good to bring down the disease as much as possible with whatever is given, and all have been tried. KPD has been tried, ELOPD has been tried. Even fractionated cyclophosphamide in Indian scenarios can be given for helping these patients. So all these can be given as a bridging therapy. Now coming to these quick points, so these are the various CAR-Ts that we have, and the controversies, I will bring out those. Bispecific versus CAR-T versus ADC. What is the best time to introduce immunosuppression? What is the best sequence? The agreed sequence currently across the world is first bispecific, then the CAR-T, and then if nothing, then the ADC. Now, if at all, if you want to use a CAR-T, you've got CAR-T against BCMA, you have CAR-T against GPCR5D, you have CAR-T against FCRH. Which one to give first? So this is a sequence which has been agreed to. Then, what is the mechanism of resistance? There are multiple reasons for resistance, and slowly CAR-T is coming up to, it started off with multiple relapse, now it has come up to 1 relapse, single relapse. It's also been tried in newly diagnosed now, rather than giving VRD upfront, and also in smoldering. So slowly it is coming to the front line, and this is how the current treatment, if the finances are available, goes for bispecifics, followed by CAR-T, followed by, as a last option, ADC. But as I said, the real world experience will actually drive what we choose over next 4 to 5 years. And these are the complications. The CAR-T complications are different. The bispecific complications are different. The CAR-T has got a very high neurological CRS complication, whereas the neurological complications are very low in the bispecifics. So the patient choice also differs. This is the final summary slide of how in a patient of myeloma should we go ahead in 2024, which was a task given to me and my panel, that how we would go ahead. So in a transplant eligible quad induction CAR-T bispecifics, in a CAR eligible quad induction CAR-T bispecifics, frail patients bispecifics, and this is how the tumor burden changes, and that's how in relation to the relapse refractory setting. And we are also talking of stopping the therapy now. So earlier we used to say continuous therapy, but like in CMLs of TFR that we talk about, we are talking about stopping therapies if persistently MRD negative for 4 continuous times at 6 monthly interval. You can stop the maintenance therapy and say patient is cured. So these are the various things which is new or which is latest as far as the CAR-T or the bispecifics and the myeloma therapy in 2024 is concerned. Sir, is that transplant eligible? So after the inductions, transplant is definitely, sir, autologous. Sir, if you see the lower part of it, the autologous transplant. So that's where we are. So I thank all the panelists. And if there are any comments which they want to add upon, you're welcome to.
Coming to your last case, she's 3.5 years post-treatment, and most of us, a practical suggestion I have, most of this are not available. So we can still re-challenge with bortezomib.
And also second transplant.
Yes. Yeah, but she was 69, so I wouldn't comment. But a lot of students, they shouldn't go that we don't have much. But we can definitely re-challenge them with bortezomib. That last patient was 3.5 years post her, bortezomib. So that is
true, ma'am.
And wonderfully conducted. Thank you.
Thank you, Dr. Uday. I think as usual, a wonderful myeloma discussion. So all the panel members also, they really explained their own experiences and at the same time, scientific evidence also. Thank you once again for all the panel members. Now